Ah. So can you we start the second day of the most important subject of this congress, you know.
O objeto desse congresso, vocês sabem, e é sobre regeneração de tecidos, tecnologias para inovação de tecidos, inovações tecnológicas para reparação de tecidos. E eu acho que temos aqui a primeira palestra, que vai ser uma introdução sobre a metodologia.
See. And this is Dr. Marcus Vinicius Melo Pinto. Yes, it's okay. It's okay. Can we have a video or not? Yes, it's okay.
Olá, prazer enorme dessa conferência, Introdução à Metodologia de Extração Cicatricial MAC, dentro do Congresso.
This is the second Congress, Joint Congress on Mechanical Vibration Technological Innovations in Health. I thank you so much, Dr. Nanubia, Dr. Mario Bernardo, for the opportunity of be talking about this introduction to scar acceleration methodology. When we decide to talk about it, we are talking about a professional history that encompasses a mechanism of tissue repair, and present the speaker, Dr. Marcus Vinicius Melo Pinto, and from that moment on we'll start to talk a little bit about our team. This is our work team. These are the researchers of the Federal University of Piauí, where our lab is located, and we started to develop this line of research, working on medical plants, the program of pharmacology, and we aim to achieve define medications, test medications that use red light. This is Dr. Paulini. She's finishing her PhD in MAC, in sacral acceleration methodology. And we are going to address strictly all the conditions that encompass our methodology and how it works. It is based in CAPS criteria 1 and 2. These are the books that we have researched on for our work, determined by CAPS, and we are going to talk about a little bit about this book, Cell Metabolic, talking about immunobiophotomodulation, and we have a series of modulation factors acting in the interaction of the light with tissues, stimulating photophysical processes, also photochemical processes in a very fast way, creating support to photopharmacology. And when it happens, signals and symptoms, one of the most important ones like pain, edema, high temperature, they are addressed by the photostimulation. We started it 14 years ago in the University of New York, working at the heart nursery, trying to intervene in clinical trials, random trials, and meta-analysis using ultrasound, thermographic, and ultrographic thermosound, using optical microscopic and atomic force microscopy, trying to mark the cell structures. When I designed MAC methodology, I designed this in mathematical function that will address the space-time curve, because MAC, it's a clinic direction interpreting signals through this math function in space and time, creating big changes in the cell structure and generating biotransformation and biophotomodulation, generating changes in many fields of pharmacological agents. Within this methodology, we respect the clinical sovereignty, and when we respect it, we see the effective advantages in MAC methodology. We see that therapeutical table. In MAC, these folds are continuous, these stops are continuous. We have a constant for delta time. We don't have the degree, we don't have a fall as we have falling moment as we have with lasers. We have a very long and high linear, so that all the fraction doses will be addressed, creating an improvement in this photonic field. Which are the real evidences? I separated them so that we can discuss them. In the traditional approach, we have some issues to address, such as, for instance, the dressings, the healing with many functions, healing, bactericidal healing, and with the MAC method, we use some resources to speed up the cure. We're using physical resources and also to determine the potential of the feedback and the systemic assessment. When we have the situation, we start to observe various types of feedback. This is the first clinical example. It's a homosexual patient had a sexual relationship, sexual intercourse with a partner that has AIDS, and we determined that we could identify this injured tissue that resulted from this sexual intercourse, and we could use this PHMB to balance the structures. We used a blue biomarker, and we also used an ointment to start the treatment. Here we have a patient with osteomyelite that we could use, in which we could use MAC with ultrasound and microscopic. MAC modifies in photopharmacology the ATP, so it changes the growth factor, the motility for the proliferation, the cell proliferation, and the deposition of the extracellular matrix, resulting in a scar that are cured, inflammation. And when it happens, this methodology is based in its principle in smoother energy, the oxygen that is triplet. And when I modify the oxygen, I improve the parameters of concentrates of oxygen, transforming this triplet into oxygen using the photonic load of 632. when we can achieve it, we improve the concentration of oxygen and the concentration of the photosensibilizer. From that moment on, the oxygen is healthy. It's called singleto. And as we use it and we improve its quantity, we can use some other markers. All that is used by the methodology for lasers and for light therapy. Something that is very, very new and innovative in Brazil, arriving through MOC in Brazil. This is the proof that the physiotherapist responds. This is a blastocyst. I prepare this blastocyte inside the immunophotobiomodulation full of bacteria and is not responding to medications. And when we use the MAC, we see this answer. We see the opening, the improvement in singleto oxygen, the tissue, and we start to see a neural answer with cartilage. And even in this image here, this is physiotherapy. We can modify the biological field of the cell structures, modifying these cardinal signs through heat, through flushing, tumor, which is a chemiotaxy, and to pain, liberating mediators that affect the nervous membranes. And we can also change all these situations and see some feedback. We published it in Photo Research. This is a tumor. This ear would be amputated, and we started the photobiodynamic modulation, and it's totally healed. It has been through these. It has visited the oncology for 5 years. Didn't have to do any chemotherapy, radiotherapy. Interesting cases here. This individual was shot. This part of the face exploded. We worked in many hands with many different types of orthopedics. 14 days after, we give him back with a better cell feedback with due to this response to the MAC technology. And all the ointments and creams that we use to prepare the tissue, there is no type of injury in this tissue. I'm showing the image again so that you can notice the speed of the process. Very common injuries in my states are these ones here shown in these pictures. We've had a very good feedback and positive response with this medicine, with erythromycin, fluoxetine. These are photosensibles, so we can enhance performance up until 88%. So there is a degree of variability. This is a facial trauma resolved in 24 hours. We have published this work with this ulcers and all these clinical situation, all these ulcers we've achieved. We achieved all the healing and the scare and the cicatrization for these injuries. We had a very well elaborated cicatrization in this case, and we started to have a degree of inflexibility. This is a beautiful work that this technology can offer us. We inoculated the virus with MAC therapy using time folds in high doses with biomarkers, with high doses of vitamin D and having an incredible response. We also published the massive effects of this therapy. We have also photosensibilized. We enhanced the neutral state of the cell, and synclated oxygen. Oxygen was also helped us to promote the healing of the tissue, giving also a better aesthetic appearance to this injury. Here we have a case of infections due to larvae and worms. We can use jaw agar, which is a ocular protector, to used in this case. We use a tweezer or a clamp that turned by the MAC technology, by the MAC therapy. We also use zinc in a proportion to treat these injuries. And how I start the MAC for the MAC therapy in a vulva trauma, in a vulval injury. It lasted for 14 days. We have developed this work with Dr. Karen in Chile. She was a former student that's studying vaginal tissue engineering, and we used the biopolymer with propolis, and we had a very good response. We had no lateral opening, and when we also introduced a probe. We also used other polymers to enlarge the opening so that she could have sexual conditions. This is a Lincoln plan. A Lincoln plan with a very big harsh, and we gave her back without edema and pain, without red spots. These are rectal traumas, especially with homosexual communities. We see it. When we use the probe, we start to treat the external part of the rectum. Please take a look at the superior and inferior part. It was bleeding a lot with a lot of prolapse, creating infections, possibly with a lot of injuries. Here we have a vulval trauma, a very big one, due to rape, and now she can, you also have a better tissue regarding what was before. We did have this vagina without response, with pain. Now we gave it back with the color, no edema, with vaginal tonus, liberated to sexual practice and to normal everyday life. This solution we had in 24 hours. In 24 hours, we eliminated the edema and the pain in the vaginal channel. Here also an injury due to rape, a fissure due to rape that we could solve. We could also do it in 24 hours. We've seen also traumas do it to delivery. We use probes, we do microscopic, we use microscopic work to see how these situations can get better. The conclusions that we have are that to combat bacteria, inflammation, and virus, we don't have adverse effects using moderate cost and has a very good potential in terms of medications. Since I don't have a lot of time, I would like to thank my association about Brasfipix, where MAC is. I thank WERJ, Dr. Mario Bernardo, Dr. Danúbia, and the PhD and master programs and the mechanical vibration lab. This is the sentence, this is a quote for the MAC therapy. If you can have an idea in your mind, follow this idea as it were a film. And we leave this message to you. The great problem to practice interdisciplinarity is the development of a language of understanding between the disciplines, between subjects. So we have to think about it. I thank you all. As this slide was brought by Dr. Danúbia, and I found it fantastic. So thank you in all different languages. This is our last book published. If you should be interested in our work, this is really interesting. I'm very happy. Unfortunately, I'm not gonna be able to be there with you because I'm in Bento Gonçalves. But I really wanted to give you this presentation. So thank you all the students, all the PhD and master students. I hope to be closer to you. Thank you. Thank you, Professor Marcos Vinicius. It's an honor to have you here in our Congress with your great scientific contribution.
And now we are going to continue with the presentation of the theme of efficiency of the vibratory therapy on lymphoedema with Dr. José Alexandre. It's an honor to have you here. Good morning, everyone. Good morning. It's always a great pleasure to be here, and thank you to Professor Mario, Professor Danúbia. It's always really nice to be here. When we thought on this theme, I didn't know the difficulty would be to, as a literature, to find. So I got really scared because I thought it was going to be easy to do. We had a hypothesis really elaborated, and I got dumped because I need to adapt it. Well, my purpose would be, my objective to be more clear, to try to sensitize all of you. I'm living on this moment in really simulated, and I hope you understand why. If we look to the importance of the lymphatic system for Many people maybe it's unknown, unexplored, but it's from extreme importance. So we could keep this balance between the fluids intracellular intercells. And when you have these different phases, efferents and efferents from the node, and has a whole system from conglomerates from these nodes. In some regions, you have more superficial ones that we could detect. And it has a capillary system, really interesting, as much as the blood system, but we had some properties that are very unique. For example, we have this. The end of the vase has absorption system with secondary tools. This flow is anchored to structures where protein structures, and then with this ending here, you have the flow is unidirectional. It's just one direction. They can fit in being directed to the node region. And the mechanisms here of absorption is this the same mechanism that regulates the microcirculation. You see the hydrostatic pressure, balance, and we remember a little detail when you're talking about colloid. You talk about solute from solid and solute, and you see a bigger proportion of solute. You have a consistency. There is more gel-like. And if there's a proportion of more liquid and a fit one, it's more common one, and this is what it gives us to work in this only gel. And then when we remember the Casifo sign, it's been used a lot on lesions and chronic inflammations. You have, of course, some depends of the signs. You are testing the degree of the gel of this colloid has. It's the same mechanism we see. We have the lymph here with his own elements from solubles and the cellular and his own characteristics. They are composed by the normal components of the lymph. And when this is all absorbed, you have some unities. They are functional ones. From the lymphatic system, you see the inflanges. They are limited by a valve in the beginning and in the end. And this difference in pressure in between the middle and the external is going to promote the flux of these fluids. And when you see this pressure here, the conditions of absorption, but of course we are going to always have a muscular tissue to give the motility for this environment. And then you have this dynamic here. You have the filling, and there's a bigger pressure inside. And then you get a stretching of this structure, and of course the muscular structure either. And then you have the contraction that generates another pressure inside. And when it doesn't have an end, you can go back. You have a proportion ahead. That which came the dynamics from the lymphatic pumping. the external strength could oscillate as like we do in this inflow of the venuses and the lymphatic system. We also had like the muscular activities. They're going to grow the external strength and going to have a better response on the intraocularity, as also the cardiac exercise. We're going to have an interrelation, all of this external system provoking alterations in this internal system and promoting this lymphatic flow directing to the blood system. And then you have an altered situation when we have alteration on these components or the external ones or the valve inside. When you have an infectious system, you're going to have inflow and going to have a reflux of the inside the lymphange and not going to have propagation of this flows. What stops you to have a continuous flow to the lymphatic system? It's when it generates in the interstitial the lymphedema. And what is important, so I do not lose this slide here, is that when it's something that it's basic, but we need to remember that all this consultation that it's here in this interstitial, they could be present to or be present inside the lymph. And if we do have a patient with high levels of triglycerides, high levels of uric acid, this is going to be altered also. So if you take a obese patient of a metabolic syndrome, there must be a great chance of him develop a lymphedema, not necessarily because of this lesion, structural lesion on the lymphatic system, but also by a difficulty of mobilization of this colloid to begin to have a constitution has less flow and it starts to repercur here on the difficulty to absorb. And then we had a difficulty to drain. And this is the physiopathological lymphedema. And so we could start to think on how we can do this, how it could be possible, the influence of the vibratory exercise in this system. As Professor Mario always said us, all the time we are vibrating, every time we are depending on this vibration. And what I have exercise of my mentorship of medicine, we have embryology class, and when we go there to the biology, we see the embryonic development is depending on the mechanical vibration. So it ends to have some thesis we have that this external strength could to stimulate the biointegrity. This biointegrity starts to propagate all these mechanical strengths to generate this system who are interconnected from all the structure, protein, or everything that constitute our body system. And this biointegrity, it's from the intracellular to extracellular, and by the time it gets to the pericellular region on the basal membrane, they could propagate to the central focus of distribution, and this starts to generate from this mechanical stimulation, generating interference on the protein synthesis. And inside this protein synthesis, we have these proteins who are going to act directly to the circulatory system. And other substance that we had on the own circulation that is going to have a phase dilatation, then we are going to happen there on the vessels is going to have a bigger pressure, and it's going to result in these conditions. They're going to interfere on the interstitial environment, and they're going to be near to the lymphatic system. And the other aspect that I think we should take ahead is that the effect of the neuromotor mechanical activation from the motosympath reflex. With the afference and inference, you have the bigger tension on the muscles. And see, there's some reference we have is that it's really old, because I confess you that I looked everywhere for some reference, and I'm not so happy looking for them. So we should start working better this hypothesis that how could be this influence of the participation, considering these two phenomena, the neuromuscular and the circulation one. The literature from the gray area, we need to appeal a little bit because we do not have so much information. It proposed this effect as musculoskeletal pump effect. You have a high of the increase of the rhythm on this frequency on the musculoskeletal contraction. It increase the rhythm of the pumping, lymphatic pumping. You generate a bigger pressure on the external mechanical pressure to the lymph engine and influence to the lymphatic flow, but we need to take for granted the circulatory questions, because when you have a bigger flow, you have a bigger pressure of the hydrostatic in the sternum, and then you have a bigger flow on the lymph that is diluted, and then you have a bigger drainage of the lymphadenum. And I lift here so you could see this picture here is epidemiological. It have a data that 15% of the world population, but we estimate that it's going to have a big increase of these markers, because 20% of the cancer patients, especially the breast cancer, the woman is going to develop lymphedema. So this is a demand we have that is worldwide in health issue, and this is why I gave you the theme, the idea that maybe the whole body vibration therapy, it's a purpose to treat, and we started to study and maybe cure with other resources the problem of the lymphedema. So thank you everyone for the opportunity.
Thank you very much for your excellent presentation, and we will have a lot of questions, I think. We go on with compression therapy in the treatment of lymphedema, how and why, and Professor Dr. Anke Bergmans is on the floor. Thank you very much.
Bom dia.
Good morning. Thank you for the invitation of the new is response. The lymphatic system is responsible for it. If we have this situation, the lymphatic system has to absorb the fluid. So we have an improvement in the responsibility of the lymphatic system in edemas and lymphedemas. And this article discusses this. All edema is a lymphedema, because before we were separating venous and lymphatic edema, and now even if we have a venous problem, this is related to the lymphatic system. And all edema is transient, and edemas are chronic, regardless of the cause. Even if we have an imbalance when we are exchanging liquid, that will generate this accumulation of liquid that could be transient and or chronic. And we have these situations like fibrosis, inflammation, dermal changes, liposubstitution with fat tissue in this member. So lymphedemas are evolutive frameworks. They start as a sensation of a heavy member, even if don't have a higher volume. If you're not treated, they are gonna be evolving to changes, even more interesting changes. And we're going to have the lymphatic reflux, as the doctor presented before. So we have fibrosis, inflammatory processes, improvement in volume, lymphocysts, and lymphangiosarcoma, which is a sarcoma in the liposubstituted tissue. So this is a more advanced lymphedema. In the inferior, in these lower limbs, we still see alterations. The evolution in lower limbs are usually even worse and harder because of this venous component. But for all these cases, regardless of the cause, what we have in a worldwide literature is the complex physical therapy as a treatment. We don't have many doubts about it. Our doubt is if I add up to the photobiomodulation, the vibratory therapy, can I add up something to this traditional therapy to have better results? So in the first phase, when we want to reduce the limbs volume, we have to make manual lymphatic drainage, compressive bandages, exercises. And then in the second phase, we substitute bandages with compressive mesh. First phase is intensive. The patient is under treatment for 2, 3, or 6 weeks. And then we have the maintenance phase for the rest of the life. And it depends also on the patient taking care of himself, herself properly. So we have good results in a clinical practice with this complex decongestive therapy for upper and inferior limbs. Regarding these two phases, we cannot treat without exercise and compressive therapy. We have the manual lymphatic drainage, but it treats symptoms, so the sensations regarding pain, sleepiness changes, this can be treated with manual lymphatic drainage, but the limbs can only be treated by adding up some exercises and compressive therapy. And why do we need compression? When we put external compression, the muscular contraction will generate an opposite force, internal, and the compressive therapy will generate an opposite force. So we have a decrease of all these spaces. So if we decrease spaces, we have an improvement of the lymphatic liquids. And we also achieve an improvement in liquid absorption. So we enhance the flow and also the amount of liquid being absorbed by the lymphatic system. This compression will follow a pressure agent, so it's going to be more smaller and bigger in both extremes. And we can do it in a cylindric limbs. If we don't have this cylindrical limbs, we cannot distribute pressure. And we have many effects of compression therapy in literature. So for edemas and lymphedemas, we have no doubt that we need compression to rebalance this blood and lymphatic system. So every time we put some sort of compression, we exert two pressures, whether it's resting or working pressure. So I apologize because some things are in Portuguese and in English, but Danubia said that I should do it in English, and the images were already set up, so I did not translate them. The resting pressure is obtained by the contact of the material with the limb while we are resting. This is a continuous pressure, and we don't need it. What we need is a difference in pressures that we are obtain when we associate to it the pressure and the muscular contraction. So when we improve the volume, we improve the compression, and so is the opposite. And it depends exclusively in the resistance of this material to muscular contraction. In this image, we can show it. When we use a material, we have a resting pressure. When we contract the muscles, we have this improvement in pressure. That's what we call pressure of work. And when we relax, we go back to resting pressure and working pressure. This difference is what we call a static stiffness index. And this is the possibility for us to improve the flow of the lymphatic liquid. So we're going to think of materials that we're going to give us more working pressure, because resting pressure does not interest so much. And this is interest because we prescribe these therapies. We use materials of 20, 30, but this pressure that comes from the supplier is a resting pressure, so we can have different materials with the same resting pressure, but they exert eventually different working pressures, and that's what we need for the lymphedemas. And they use this device, this pressure device, a pressure sensor. So when we have a less flexible material, we had the 40 as a resting pressure. It contracts and goes back. So we have this stiffness index that is higher than what we obtain with elastic materials. So we have the same resting pressure, but if the material changes, we have a working pressure that is smaller. So what we need is materials that are low in elasticity. But of course, we have other issues here because, for instance, we have isometry. We're going to have an enhancement in resting pressure, but we don't need resting pressure now. We need working pressure. So materials that are not so elastic, and they will contract and relax the muscles. So we go back to the vibratory platform. We can see that it might help also the treatment because it promotes this relaxation and contraction. We have other treatments, such as the compressive bandages in the first phase when we need to reduce the limb volume, and also when we can reduce it, we go to the second phase with compressive mesh, which is the traditional treatment. And we've been having available in the market the self-adjustable devices. We already have 4 companies commercializing these Velcro devices, and they will substitute bandages and mesh. The advantage is that the patient can adjust it self-adjusted as the volume reduces, giving to the patient more autonomy. Because the patient can take it out to have a shower, for instance, and then put it back again. So the idea is to give more accountability to the patient in the treatment and reduce costs, especially related to the first phase. So the first phase, we have these bandages, compressive bandages. This clinical trial in Inca, we compare two groups. The first one with the complex therapy, with and without, in the same without the lymphatic therapy. So adding the lymphatic drainage did not cause the reduction of the limb. So the base of the treatment is the bandage associated with exercises. For us to use the bandage, we have to go back to Laplace's law. The pressure depends on the layers of the bandages, the tension of the bandage, because they have low elasticity, not to enhance stiffness and pressure. Depends also on the type of the limb. So it depends on the circumference of the limb. Some bandages are used exactly to distribute depression throughout the limb. And also depends on the width of the bandage. So we have smaller circumferences, and when we have bigger circumferences, we have this difference in width. The first thing that we see is the form of the limb. If it's conic, we can apply the same pressure because at the bottom the circumference is smaller. But if I have limbs that are symmetric, I have to use more pressure, more pressure in the bottom than in the top, because I have to compensate with the bandages. So I'm gonna use more pressure at the bottom than in the top to compensate. And if I have inverted limbs, I have to have more pressure when where it's bigger and less pressure where it's not so big, since the circumference is that part is smaller. The liquid may not go up due to the difference in pressure. And we can also use internal layers, and we should also make so that the limb is cylindric to distribute the pressure. So we always have to make it cylindric and protect the bones structures, not to create ischemic situations. So bandaging have different layers with different objectives. The first one are the tubular meshes, the second internal foams, and the third are the bandages with low elasticity, and they are the ones that will create this distribution of the pressure. We clean the skin. We use the tubular mesh to protect the limb against the foams and make so that the material will last longer. We change it every visit, or whether we replace it or we wash it. And then we put the internal layers, so I'm cylindrifying less. I'm improving the pressure in the fibrosis area. We have the foams, and it's mandatory to use this concentric mesh. It's a concentric pressure to adjust the internal foams and make the limb cylindric, protecting bones. And so after that, we can use the compressive layer, which is the last one, giving the working pressure to the limb. The amount of layers that you use is what make difference, and also the degree of pressure that is applied. This is the biggest difficulty we have because it's a chronic situation. We can also reduce with the bandages, but to keep this volume reduced is very difficult. We've been following this patient for 20 years or so. This is the first result, but then she had an osteomyelid, used radiotherapy, and then the volume increased because of the therapy. So the patient is always, having this difference of being through these situations of increasing the volume and decreasing it. We have different types of compression, of meshes, and for each for each limb volume, we have a different mesh that can be used. And first of all, we have to understand which are the wires, which are the threads that are used. And the way these threads are created and the way they create the mesh, and we have circular meshes, we have plane meshes with more working pressure, and the plane meshes are the ideal ones for more working pressure. And here we see the big difference amongst them. Circular ones promote more resting pressure, and the plane meshes promote more working pressure. So we should adapt these plane ones. For lymphedema and for edemas, we can use the circular ones. With this, we have these recommended compression levels, and they correspond to the resting pressure. But the working pressure is more important in this case. We have to see where the lymphedema and edemas are located. We have all the structures of the body that need compression. We're going to see the shape of the limb, where it is located with a lot of fibrosis or not. And if the patient is able to place the meshes, to use the bandages alone independently. We have also the self-adjusting devices with Velcro that can be used and adjusted and placed by the patient. This is the idea, that the patient can place the bandage, we adjust it, and then the patient goes on readjusting when necessary. We have it for the hands and for the arms. They are different. Patients bite accordingly. We adjust the pressure like this as we use the Velcro and adjust it to the pressure that we want. This is our protocol. We have compared the devices. These results are not yet published, but we know that devices and the bandages were able to decrease the size of the limb. So for lymphedema, initially they are a possibility, a therapeutic possibility. We published these case that the patient reduced by 30% the limb size with the Velcro, and then we compared Velcro with mesh in the second phase, and we saw that both of them presented the same results. That's all. This is my contact and my invitation for next Congress.
Tu pega água pra mim se tu sair.
Huh?
For your presentation, very nice presentation, Professor Blanque. The last lecturer is in English, is best for me. Effect of systemic vibratory therapy on tissue repair, and this is Professor Thais Porto Amadeu. Merci beaucoup.
Good morning, everyone. It's a pleasure to be here with all of you again. I'd like to thank the opportunity, the invitation to be here. It's always nice to be close to my friends and new and future friends. So the idea now is to talk about the effects of the whole body vibration on tissue repair, but specifically on the tissue repair, the skins. And who doesn't know me? I'm professor associated on immunopathology and microscopy on UERJ. I work on a lab of immunopathology with Luciana Rodrigues, who is coordinator the postgraduate program. And I am leader of the CNPq group of infectious process and chronic disease and leader of health education. And I am vice coordinator of the master's degree program in the health, laboratory medicine, and forensic technology on Biology Institute of UERJ. The aim of this lecture now is to author how to understand what is in the literature and what we can do with some study reference to the whole body vibration or repair tissue on the skin and in human and murine pathological and non-pathological conditions. So just to start, I'm going to talk about the tissue repair, why to study this, the effects of what we see in the literature of the exercise on the wound healing, what the literature evidence of vibration therapy effects on skin wound healing, and the effects of this whole body on some models and animals. The tissue repair is the extremely physiological process which is necessary to happen after aggression to a tissue or various tissue. This process we have to improve and reconstruct the physiological system to reconstruct the tissues. So the intensity of this aggression and the answer of the organism or the depth of this lesion could happen in the regeneration or a wound healing, like a scar formation. And this process is divided on phases, so you easy the comprehension of the physiopathology are events that happen happens at the same time, who are complementary and allow you to through this process have to the end the formation of a scar tissue. So you have to begin inflammatory phase and then granular tissue and then maturation and then remodeling. And this process was so complex. Why it's so important? You have the lot of cell types since the beginning of the aggression through the inflammatory phase and then the extracellular matrix components like collagen and the mediation of cytosine and hormones and other molecules. And more than that, we have the interaction between all of these components. So when you think of aggression to determine tissue, you can't see these components isolated. You need to understand they work in together and to have this aggression to be repaired. And this process starts to happen gradually and normally. We hope to be like a physiological. You have a flow of the blood and being overflow to the vascular system. It's important, so we start the healing process and the formation of the granulins tissue, then we start to have the revitalization and then the vascularization of this tissue, and then we have this tissue where the granuloma is going to start to have a scar tissue. Some cases we have, because it's not so perfect, the healing can be compromised, resulting either in two possibilities: excess of healing, it's mean the fibrosis, or it's the like keloid, or you're going to have a slower healing or not having a healing at all. So it could end the process of healing and you start to have ulcers. Of course, you have these lesions, like a chronic lesions. They start to happen because of the time of the treatment, the cost, and the treatment. So start to become a great problem to the public health and can be an amputation of the limb. So you have some chronic lesions like a venous alterations or arterial one. You can have a lesion from the venous or arterial, or lesions that are really common are diabetic lesions, as being scaticals or neuropathic, or depression lesions were really common to the like elderly who stay lay down and compression of the tissues. So the process of repair has an influence of many factors. There could be local, like infection as the extreme important factor. Like diabetic patients, you have this potential of inflammation. The ischemia who is present on most part of this arterial alterations, elevated tissue pressure, and the edema comes from the inflammatory process, and of course the presence of the strange bodies and other factors can be influence the system. Is the self-medication or the medication used at all, the malnutrition, or if it is obesity, or you have some chronic diseases like diabetes, if you smoke, and we know when the patient smokes, the use of the cigar have some damage to the tissues. The socio-economic conditions of the patients, we're going to reverse to the condition to the treatment, and if this patient could get to the informations like the taking care of the wound and the age and the physical exercise. Of course, now we know all of this, it's still a big problem. So we need to understand how much we need to do to accelerate this process. And we have a lot of strategies to accelerate the process of scar tissue. And thinking of those chronic lesions, it's the exercise to understand as a relative low-cost intervention strategy that can be clinically used to prevent and treat impairments in the wound healing. And there's a lot of studies in the last 10 years that showed us the effects of the exercise and the wound healing on diabetic patients or chronic lesions, venuses or arterial, that are related to elderly patients and also experimental patients. When we talk about exercise, we are in a congress of vibration therapy. So the exercise that is potentially important that can be used, so we could have vibration, the whole body vibration exercise. So this study have been carried out with the aim to clarify all possibilities to benefits the vibration therapy. So the study had shown over the last year then muscular healing, bone repair, nerve tissue repair, cutaneous wound healing. And what is the vibration therapy can do to the wound healing? Study happened on the 11P with the systematic review that showed that some studies, and most of them were experimental, have been accelerated the wound healing on diabetic patients. One of these studies was from 2014. They're using some rats with diabetes with a mechanism of vibration, who showed us really important to have a low intensity, have some alteration through the control of this intensity, accelerating the wound healing, especially after 15 days of the scar tissue. And this from the increase of the VGF, ingrow factor, and insulin ingrow factor. And other studies from 2017 in rats also showed us that in comparison to the electrical stimulation to vibration, the acceleration of the wound healing, showing this effect who is important on diabetic ulcers. Most recent work showed us in 2023 in patients with a lot of stages of lesions, compared to patients who are not being treated with this tool to stimulate the vibration. During the use of this intervention with 12 weeks showed us the acceleration of the wound healing related to the control group. And why we had start this research line of scar tissue? Because even with all these studies, we don't know what is the real effect of the whole body vibration exercise through this process of the scar tissue. So through the projects of Alan, Danube, and Mateus, we use rats, half oyster ones. We started with healthy rats, so we could have an effect. So the whole body vibration platform has an effect on the individual with no comorbidity, because we do not have on literature in health individual. So we do the lesion on some animals with anesthesia is 4 centimeters square, and after the first day of the lesion we do for 14 days with the 4 days of rest. We use the vibration exercise, and the peak was 7.85 G-force. And these animals are in some places were being pathogened by the group. We put them to be a whole body vibration exercise. We define this group as a sham group and treated group, and the sham group they stay and the exercise the same way that the rats, they stay in the same stress that the animal who are in the cage, but without the vibration. And then we see after 15 days the sacrifice of this animal and do the histological and microscopic analysis. And then we have the lesions of these animals from shown group and treated group by vibration. Unfortunately, we couldn't see difference that are significant, but we see a little reduction of the contraction of this wound in the treated group to the control group. On the analysis, histological with amatoxylin and using, you see the group, control group and the treated group. You have on the treated a more advanced healing, and the granulated have less inflammatory cells. And with more details, we see this epithelium with the neoepithelium, and then you see more developed from the animals who are treated with the vibratory system. And through the coloration from collagen, we can see a difference on the organization of this collagen, but we see that these fibers on the treated group, they tend to be more longitudinal arranged related to the scan group who is more fragmented. And we also do a histochemic on the fibroblast group, some markers, and we quantify these phases, and we show that the treated group increase the expression of actin muscle by the angiogenesis process. And here in the images, you see a bigger phases who are treated related to the control group. We also do the immunohistochemic, is the galactine-free. The galactine were being related to a lot of wound healing and fibrotic, and we see the group that were treated with the fibrotic group express more with the galactine-free related to the control group, and we see there is a significant difference. So this data is going to reinforce us that the importance of the mechanical vibration, the importance of this effects of this vibration on the mechanical process of the wound healing. And of course, we need more studies so we can explain these effects, especially to what respects on the pathological conditions like diabetes. So I invite you to visit our poster from Mateus, who is our doctor student, and he's going to show us our initial results on diabetic patients that we already started. So thank you for your attention. Here's my contacts. Thanks to my students, because without them we didn't do anything. So thank you, everyone.
Very nice presentation. It's yes, we finished. Yes, discussion. We can start the discussion. I call the lecturer on the floor to be here and can answer the questions in the room, please. Alexandre Bachour, Professor Bachour. Professor Bergmans, Professor Amadeu, and yes, Professor Pinto, but He's not online. Okay.
Of the pretension to prepare all the compression system and tension and expansion, but how do you prove it? What's limiting me? Do you have echography that can give you the amount of tension in the place? Not in a general way. With elastography too?
Possui, you showed us the pathway, protein pathway of mechanical signal. Do you know if you have some genetic rare disease that impact protein of these pathways and can be a solution to see what of growth factor is impacted or not? Because with rare disease is a good solution to best understanding. Do you have notion at this?
Ele está perguntando sobre a.
He was asking about the protein constitution. Is it? The protein constitution of the interstitial. Is that it?
This using rare disease to best understanding the signal pathways of mechanical signals, you know, because you show these pathways with protein,
Okay.
and with genetic we can see if this protein is impacted and it impacts the signal mechanical transmission. And I don't know if we have models on that.
É isso que eu entendi, né? Ele quer saber qual seria a dinâmica.
Well, it has to do with biointensivity. What I have as information from literature is that the network, the collagen network, and we have different types of collagen with different types of molecular structure, some with more molecular resilience and others with less. And I don't know if this is the path you're looking for, but this mechanical vibration, the way it is spread, would lead to a generation of energy that would be dissipated in receptors, and we have BSO1, BSO2 receptors that could create a intracell signalization to liberate some cytosines. Is it what you're asking?
Thank you very much. Can be deficit.
The fibroblasts are mechanically sensible, right? And this will create a modulation. So fibroblasts are provenly to be mechanically sensible because they have receptors. And out of the receptors that I know, BSO1 has a membrane, as a cell brain, and PSO2 has a nuclear level.
Feel so much, but we need to finish the discussion because the time. We want to give the certificate, participation certificate. Do you want to give Danubio or can I? Yes? Okay.
Bom dia.
Good morning. Let's go on with our roundtables. Now we start the roundtable number 4 that deals with technological innovations and metabolic changes. Let's start our lectures of this table with the first one, analysis of intestinal microbiota as a health marker, lectured by Professor Dr. Antonio Martins Tiepo. Thank you. I'd like to thank you, Professor Danubia, Professor Mario, for the invitation to be able to participate at this wonderful congress. Our theme is a lot interesting to this congress. Human, but also vegetal and animal microbiota has been going through a revolution due to technology innovations. I think they got the wrong lecture here, the wrong slides. But I think it won't take long. This was a strategy for the rest of the public to be able to arrive. Our theme. This is my academic career. I don't have any interest conflict for this presentation. And let's talk about human microbiome. As you can see, it's a growing interest issue. For the last 15-20 years, even more microbes are being researched. And if we can just put here the landmarks of microbiology, we can start in a hidden period going back 4.5 billion years ago, where we only had rocks. But as the next period started, after the radiant one, we had the freezing period, the Archean period with the oceans, and the cyanobacteria, maybe mechanical vibrations, interactions of organic molecules. And these mechanical vibrations might be here in the origin of our life in the earth. And from that moment on, cyanobacteria had the capacity to form bacteria in rocks. The cyanobacteria started to oxide the planet, and 20% of the oxygen in the atmosphere at that moment was produced by cyanobacteria. And 2 billion years ago, we only had microbiotic lives, energy being produced by anaerobic processes, anaerobic glucose, and microbia that was using oxygen. And 2 billion ago, through endosymbiosis, there was the union of a being producing life with oxygen and without oxygen. And these two beings got together, united themselves to create life. And Anton von Leeuwenhoek in Holland, in the Netherlands, was a scientist producing microscopes and produced many of them, and had this thing of looking at things through the microscope he was producing. He was the first one to discover the bacteria. This is another important landmark. The pathology and microbiologist, German microbiologist, Dr. Heinrich Hermann Robert Koch, first established the relationship between bacteria and sickness, and discovered the tuberculosis agent, which was a bacteria. And in the 1900s, we had the first bacteria cultures. At that time, we used the anaerobic bacteria. And a very important landmark research performed by Carl Woos and George Fox in 1977, when they found out about a new dimension of life between prokaryotes in eukaryotes with an organized nucleus, which were the archaeas. And in the middle of the discovery, they create a technique to create a sequence of the genes expressing the RNA that has a very specific character. So regardless the culture, I could identify in a given sample, what kind of microorganisms there were. And Peter Thomberg from California in 2006 transplanted feces from people with obesity in rats. And he made so that a group of rats transplanted with feces from obese humans, and also he separated a group that did not receive the feces, and the group that received the feces basically became obese, just like the human, presented the same obesity issues as the humans. And Dr. Haja Sekaran discovered, researching on body microbiome, that there was this population of microbes inside the individual and inside of the lumbar intervertebral disc. And I'm sorry if I am putting this line here, this timeline for you, and I'm putting myself in this timeline. I apologize for that, because I'm not to be compared to the others. And in 2024, we analyzed intestinal bacterial microbiota in individuals without chronic low back pain. So they were not really elderly, they did not smoke and did not drink alcohol. And we found out that there were significant differences in these people, because in the first group, this bacteria had a pro-inflammatory profile. Here we have our work published in this paper. So what's the microbiome? It's a system that is complex and abundant of microorganisms that are in our organism, made by fungi, bacteria, archaea, phages, and I have to run because we are short in time, but we can discuss later on some other details. So we are talking about this group of microbes that are in our organism, in our cavities, and we are also we have this concept now of holobiome, that we are what our genes are, and also the genes of our microbiome, of the microbes that are in us. And these microbiome, this holobiome, is in our intestines, and they are divided in Firmicutes and Bacteroidetes. And we have the further division in actinobacteria, proctobacteria, fusobacteria, and microbia. And we have 23,000 human genes and 2 to 20 million microbiome genes. Some of the characteristics of the microbiomes are presented here. The ideal thing is that it should present diversity, and it's also redundant. We have different bacteria producing the same subproducts that are beneficial to us. Each of us have our microbiome signature, depending on how we were delivered to the world, which context we had during our lives. So it's very specific and can change in time because of our lifestyle and our food. So if you develop a microbiome that is very good, even if it's destroyed partially, it can be recovered. It can regenerate. We also speak about alpha diversity and beta diversity, and I want to explain it by showing to you these two samples. We have 4 different colors, 2 different taxes, and the richness of this first sample is 4, and the abundance is proportional. In sample 2, we have the same richness but different abundance. If we say that the red lines are bad, and I can identify that I have more of this red microbiome in the second sample. And the difference between the sample 1 and 2 is this diversity. The functions of the gut microbiome. Each of these functions will allow for many orientations, but let's just talk about the barrier. If I have populations in my intestine, usually the ones I have the probiotics related to the health, and then others that are not. So these ones protect me from. They create a barrier that protects my organism in a systemic way. The presence of these microbes in my gut, it helps to produce a balanced state of my immune system. Bacteria, microbes, they help in digestion and absorption. We don't have beta lactase. We express alpha, not beta lactase. Some food that are digested also by our bacteria. They help us digesting these food and other types of minerals, especially in some parts of my gut. But if my gut is not acid, the absorption is not so good. And probiotic bacteria, they produce some acids that will make so that my gut will become acid and absorb some minerals. So even if you have, if you lack some minerals that are very important for our organism, and through this perspective, I already have my health damaged. These molecules, vitamin K, vitamin B, the short chain fat acids, they have effects in regulating our immunology and an imbalance and regeneration. And the short chain fat acids have anti-inflammatory properties, and they, for instance, are able to act to create regular lymphocytes that are regulators. These fat acids are also responsible for incretin release, like GLPI1, PYY, which are very important molecules for insulin. And if you want to be healthy, you really have an insulin that works correctly in your body. So our conclusion is that products with gut microbe, they act to improve our health or to damage our health. So we are focused in markers, the microbes as markers. When I talk about chronic disease, I always have to talk about chronic low grade or not low grade. So it's an inflammation that instead of just, disappearing, it persists, causing chronic pain and so many other chronic diseases and conditions. So when I have a persistent chronic inflammation, I also have the same feedback And Thais said we have this inflammatory feedback that creates a certain response. And we activate cells in a very specific pattern that produces cytokines. This inflammation that is persistent makes so that the repair and remodelation will not occur and inflammation will remain. And Patricia Houston published, Dr. Patricia Houston showed that macro environment, our social relationships, social cultures, if they are not adequate, they will impact the lifestyle. And lifestyle impacted will be impacting also the functioning of our cells and in molecules, creating chronic inflammation. Dr. Miller shows in a recent paper researching inflammatory markers with people with bad lifestyle that they are increased 1.4, 3.8 times. And the excess of inflammation is very bad for our organism. And as she said, lifestyle, it's very important. We are talking about sleep, nutrition, and exercise. Sleep is the proto state of life. In California, studies show that first we were sleeping and then we woke up. And REM and non-REM phases that are fundamental and growth factors, and also other factors of these sleep will impact our gut microbiome. And nutrition that should also provide for macro and micronutrients and also impact in my gut microbiome to protect me. Exercises are much more than just movements. The muscles will produce a lot of elements that are such as myosin and irisin that will result in a regeneration of tissues and impact directly in our gut microbiome. And I commented yesterday, someone in India published in 2019 a paper with whole body vibration that improved the gut microbiome. A bad gut microbiome will produce a lot of damage to the body, especially to epigenome, microRNAs that control our genes. This type of damage will cause high intensity inflammation. Now we are evolving in gene addition, but it's better to just improve your lifestyle. So how do microbiome produces this? We have dysbiosis, the alterations of the microbiome characteristics that we already mentioned before, and this dysbiosis will reduce probiotics. And this dysbiosis is characterized also by a barrier break. Several barriers that we have in our organism. And this barrier break will make so that local and systemic translocation of bacteria, their constituents, and or metabolites. And just to give you an example, here we have a dysbiosis and a barrier break. And I have a toxin that is very important here that I have when I have dysbiosis. And once it's displaced, it will activate cells that will go to, and they will activate CD4 lymphocytes and pro-inflammatory lymphocytes, creating an inflammation in our bowels and our gut. And these cytokines and these cells will produce other conditions in different organs. And that's why now we deal with different axes. Thinking about joints, a mechanism that will compromise LPS will be the translocation. So it can activate it or not. we can activate macrophages through TLB4 and produce the dysfunction of some cells and damaged the functioning of the bile and producing proteins that will further degrade the joint. And these tissues will stimulate inflammations and influence the transcription factor. So how do you improve the gut microbiota? So pay attention to complaints. If you have, some issues, some conditions in your gut, it already says what type of microbes are in your gut. Work, lifestyle, multimodal modulation of the gut. There are many orientations, many guidelines in terms of exercising, sleep. Use prebiotics for bacteria and postbiotics, which are the products that are produced by microbes. The restoration of the modulation will help to retrieve this barrier that was damaged and reduce all of this reduces the inflammation and the pain. Thank you.
Congratulations, Dr. Antonio. Excellent presentation. I'd like to call now Professor Dr. Danubia, who is going to talk about vibration therapy on diabetics and metabolic syndrome. I'd like to thank the presence of everyone now, and especially the integrants of this table. Like I said yesterday, it was a congress of meetings and brain meetings, and in fact, we are seeing great friends again. So we have a purpose in this table, in this lecture, to talk about the systemic vibratory therapy in management of obesity and metabolic syndrome. These are two projects we have in our lab. Metabolic syndrome is an older one, and obesity is the new one, and we're going to present our results. We have a short time, so I can't show all of them, but we are going to. We do not have all the analysis, but we are going to show a little what we had. We have a brief description of what I am today. I'm professor at the University of UERJ, director of the Teaching and Research Department, head of Laboratório de Vibrações Mecânicas e Práticas Integrativas, young scientist of Rio de Janeiro, young woman scientist of 2023, and other institution that I'm president or vice president. I declare that I have no conflicts of interest related to my presentation, and this is my brief definition of what is the obesity. It's a complex chronic condition with a complex condition. We have diabetes type 2, we have the increase of vascular system and other syndromes, and we understand from this complex the difficulty we have to better dealing with the approach of these patients. And all of this alter the quality of life, the sleep, and also mobility. And the diagnose, and when we talk about obesity, we see some parameters. I mean, we can see, but what we do, the mass is the index of body mass is what the BMI. We have a publication as we do a comparison to in relation to the analysis of this body composition with a lot of index we can do on the clinical practice, because we see the anthropometrical measurements and the adiposity, and you can see a better result of the body composition. We see all the fragilities of the BMI, but we do use this as our large scale, and we, as a relation of metabolic syndrome, we have some factors as a predisposition, like sedentarism, being overweight, and to also to diabetics. We also had a vascular risk enhanced, and there are two conditions. They could be or not associated, and what contribute to this increase of the cardiovascular lesion and related to diabetics. And some of the diagnoses we do this in our project. We use we have an increase of the fat accumulation of the abdominal. We see low HDL. We have elevated triglycerides, hypertension, hypoglycemia, and some of parameters we follow up. And talk a little bit of what we talked before. The difficulty to work with is to approach the patient with obesity of metabolic syndrome is related to the practice of exercise, health of foods, and also medication you can have, especially on obesity. As what we've been said before, there's not only one approach we can have. We can do a lot of one. We know what is the difficulty. We just said some of the approaches we can do. We can focus none of them. So we are going to talk about the exercise. And when we talk about these patients, we have a lot of possibilities of exercise. They can be work, telling. It has to do with the phenotype, the predisposition, and the individuality of the patient, the somatotype of every individual. And these patients in general, they don't like to do exercise, and there's a difficulty to do a protocol with exercise. And we have the certain vibratory therapy, one of the options we have, but there is a great relevance because this is exercise. There is the rate of function. There is a low impact on the effort, so this individual doesn't get tired. So when he had the idea that he's not doing anything because the machine is doing for him. So when we talk about someone who doesn't like exercise, it's really well because it's like a medicine, because it's something that is doing for him the exercise. So there's a sensation, oh, it's vibrating and I'm not doing anything. It's just a machine. So the patient continues to do it. We have some publications that are beneficial to these populations, and we've seen that this is being motivated to start a practice. So we have some benefits for the population when we see on the publications, and also in our research. At the end of our protocol of research, this person is more motivated because it have a better improvement on their bodies and they so he says in the end of the protocol, I don't want to lose it. So it starts to have a protocol to start an exercise, go to academy or go to the gym, and then is a factor that start to help this individual to going from the inertia to the exercise. So when we talk about this modality of exercise, we have, like any other, some particularities. And when we think about this is being used, where it merged, so we see at PubMed, we see that through the time we've been grew from metabolic syndrome as obesity and in general. So there's a technology that is not so new. If we're going to evaluate is the use of the vibration therapy. It's from a long time ago, but talking about the platform, we have some registered from it's could be started with the astronauts on the 60, and then they came with some studies regards to do this study. So this is a modality from exercise, technological innovation we had in the last years. So this study is that like to show people. So when you're thinking how to elaborate a protocol or to understand better this mechanism, this is an option. So teach me how to build a protocol, but this is a deadline because you see that everything you need to put in a publication so you can do this regard to this modality of exercise. So if I need going to report, I need to put it on my study. So this is a guide so you can do elaboration of protocol with all the parameters. So you say you need to talk about it, so you need to have the data. So just to highlight, our group was in the elaboration of this protocol. The guideline, international ones, it was elaborated by a team of experts, international, related to the subject. So here I put you some of the platforms we had. We have some portable ones and not portables. And we also had, basically, for who doesn't know, what happens is that these types, it differs how much this basis of the platforms alternates. They are alternate and it works like elevating one side than the other. And when we are closer to the center has less oscillation when we are afar, and then you have more oscillation. And we have this example of a platform in the space of going up and down, and another one who is with 3 axes is going to work from the back and from one side to the other. So the individual doesn't stay rounding, but it's resulting to this movement. It's only feel this movement going up and down, and you only know if it's a vertical or tri one. We can use some tools and to try if this works in different axes. Some possibilities we can use it. It can be used associated with other technologies. A patient who is in the bed using the base of the platform. Here's a kid with imperfect osteogenesis doing the use of the platform. It's possibilities that we can use research like the only one, like the patients on the then in the hospital we can go out in the to walking, so we bring the platform so we can use it. So to understand, and I don't have time to explain the parameters, but it's important so you can understand in some articles from the subject, and most of them is going to give you frequency, is the numbers of cycles per second, the peak to peak, or the displacement amplitude. And one thing is not the same thing. The peak to peak, you're going to dislocate from the minimum peak to the maximum peak, and the amplitude is the half of it. You said use 3 of amplitude, and I only know the peak to peak, so you're going to do the math and know then put the 3 at the same of my platform because they are different results. So just to understand what is one and what it is another, it's not the same thing. I'm going faster now because I have a little time. Another practicality we had is this exposure time, how much time the patient is exposure to the vibration, and the number of sets it has. Like the patient is going to be 10 minutes, and then it's going to do some flexion, and you're going to have a high accelerated on the hand. So you're going to rest a minute and then do again 10 minutes and then to rest 1 minute, but I can't have 30 minutes directly. So you need to do a little rest because you can use the equipment you buy on Polish shop, on the gym, and think can have for an hour, like a long time, and it can't do it. You need to rest between the times. And when we talk about the evidence by obesity and metabolic syndrome, I have some works like this I did in collaboration with Italy professor you saw yesterday. Alessandro Sartorio professor, he has acute effects of whole body vibrations alone in combination with maximal voluntary contractions on cardiorespiratory, musculoskeletal, and neuromotor. And what we see is that this study included 8 obese male adolescents. They have a center of treatment. That's why we only have adolescents, and they were shared between 3 groups. One just did a vibration, the other with contraction, in other just the contraction. And then we have the specification of platform, the number of sets, frequency, amplitude, and exposure time. Now we have some variables. You see the acute effect on the cardiorespiratory system and the musculoskeletal, and the conclusion was a little bit of what we said before. The results was considered low impact, viable, safe exercise and capable to positively influence cardiorespiratory and musculoskeletal function. To positive effects, the WBVA may be beneficial in physical rehabilitation of these individuals gradually introduced to physical exercise into their lives. So this speaks a little bit what we said before. So I brought this is from another doctor from our group, Ana Carolina, who did revision of the evidence of whole body vibration in individuals with metabolic syndrome. And just to highlight, because till yesterday there is no literature, and our group is the only one who has research and studies about this topic. So all the works, they are included from our group because there's only then on literature. And then we have this review of 132 participants. You see 1 to 10 weeks because some of the works is still available to the treatment, but the protocol is only 10 sections. And the 1 day is not because we evaluated by 1 day only. And it says there's the frequency, the number of sets, the peak-to-peak displacement, the exposure time, and the positioning that needs flexing, like we asked before. Some of the results we have the quality of life, the functionality, neuromuscular activation, body composition, and flexibility. And we also have the variables and pain level and cardiovascular response. And the conclusion that I had is this format of protocol is a better response to quality of life, flexibility, mobility, knee range motion, pain levels, mobility, safe quality, and body composition and functionality. So we're going to go a little rep. The protocol developed for LaVimpi to obesity is using 2 models of platform. And in this group we have a vertical platform and the other the self-alternated platform. Have the purpose to compare both of them because when we are talking about SUS, we are using the one is 8,000, one who is 60,000. So it's because if they are similar, I'm telling you, you don't need the 60,000 one, you need just the 80,000 to the health public. So you came with this work from Professor Aline for our group. Is the evaluation of effects of whole body vibration exercise performed on alternating hierarchical vibration, on thermogenesis, body composition, muscle strength, and functionality in individuals with obesity, and we see improvement of these individuals. They prefer to use the vertical platform or the side to side. And what is funny to see is our side-to-side platform. We have some similarities to the results, but some of the alternated is going to be highlighted because what is interested because it's cheaper. And this is a work from Ana Gabriela is our student. We have evaluation of the effects of systemic vibration therapy of modified cardiovascular risk factors in adults with obesity. We have these effects, the significant degrees of BMI, significant degrees in HDL and LDL. This is the work of Alessandra, who is seeing the effects of the systemic vibration therapy on heart rate variability in adults with obesity and has a better regulation. This is the work of Jennifer, who also seeing the body composition, quality of life in adults with obesity. We have improvement of the neck circumference and waist to hip ratio and the quality of life. We have work of Gabriel. It's also talking about the effects of vibration therapy system on muscle strength and functionality in adults with obesity. We have muscle strength improved. It's the protocol of alternating platform from metabolic syndrome protocol. We are changing this protocol from 5 to 16 hertz, and the another one I didn't say, but it was 30 hertz. So on the obesity we did 30 through all the protocol, and now we see the 5 to 16 increasing then through the time, and also increasing the time of exposure on the metabolic syndromes. And this is the work of Carol, who ended as our doctor. Tell about the effects in relation between functionality, flexibility, quality of life, sleep quality, biochemical parameters, and we had improvement of quality of life, improvement of daytime sleepiness and sleep quality, and reduction in glucose and glycated hemoglobin, reduction in uric acid levels. It's also the better connectivity index and the reduction in waist to height ratio. And some of the projects we have is osteoarthritis, decrease of risk of falling, autism spectrum treatment, scar tissue, the animal model, obesity, metabolic syndrome, pulmonary obstructive chronic narcolepsy, associated use to the cannabidiol, and also to, as a conclusion, we see the improvement of parameters and muscle strengthening in both patients with obesity and also metabolic syndrome. I'd like to invite you from Mevitih from next year. It's going to do for 4 years because increase research from 4 to 7. There's a picture of my group, but since there is no, I would like to thank everyone, the presence of everyone for Living P. There was a picture of them, that picture is not here, but it's a thanking to all of you. It would not be possible without all of you.
Professor Danúbia, thank you for your excellent presentation. I'd like to invite now Professor Dr. Maria das Graças Rodrigues de Araújo for the lecture Whole Body Vibration in Diabetic Patients Partial Results. while they organize. Since I was one of the last to speak, I would like to thank you for the invitation. It's an honor, and since the moment I arrived, I said this event should change the name to be called an event of meeting again, regathering friends to study, transmit, and discuss data that we have brought. A brief presentation of myself. I'm a full professor at the physiotherapist department at the Federal University of Pernambuco. I'm a coordinator. Not anymore, actually. I'm a vice coordinator of the program of post-graduation in physiotherapy of the Federal University. I'm a coordinator of the lab of kinesiotherapy and therapeutic resources. We develop our researches and give support to graduate to the graduate program. I would like to Rubia and the other student to stand up and come, because they came here to give me support and participate at the Congress. And I am a recent member of the Academy of Arts, Letters and Sciences of Olinda, Alco. We are called Confreda. It's one of the biggest gifts that life has given me. And you are invited to go to the Federal University of Pernambuco. This is our main entrance. We have the campus in Recife, which is the oldest one. We're expanding to the Agreste region in Caruaru, and the Cave in Vitória, Santo Antão. Before, we were concentrated in Recife, and now we have to move to the rural areas too. I'm bringing to you partial results of a PhD student about whole body vibration in diabetic patients. And why have we chosen diabetes in our program? We are talking in our program about aging, comorbidities, and we study osteoporosis, Parkinson, and diabetes in elderly. And this called our attention. IDF 2021, which is the 10th edition of the International Diabetes Federation's report, we found some data here that caught our attention. From 20 to 79 years in 2021, and we are now in 2024, we had 537 millions of diabetic people in the world, and 240 millions underdiagnosed, including in Brazil. They use this data as reference. We have 31.9 million of people underdiagnosed, and the projection for 2030 is of 643 millions. And it's incredible because we're going to arrive to 783 million in 2045. And we have worldwide 6.7% of deaths due to diabetes. Projections in 2021 say that 4.2 million people died in 2021. And also cardiovascular diseases come together in this package together with diabetes. I won't give definitions here because it brings a very small brief explanation of what diabetes is, what it causes, and what it leaves as consequences. We heard Professor Danubia talking about obesity. That is also included. It's theoretical, it's literature. So what am I going to bring to you? The effect of force training associated with whole body vibration on peripheral circulation and functional mobility in elderly type 2 diabetes. It's a controlled clinical test aiming to verify the effect of strength training associated with whole body vibration on peripheral circulation and functional mobility of these individuals. What have we assessed? The speed, the blood flow speed, in peripheral blood flow. So look here, we used the Doppler device. Our region of interest was posterior tibial artery and dorsal artery of the foot. We heard the sound, but we could print the speed. So we have the registrations of all these patients. We will assess using temperature the peripheral circulation using this machine, thermographic machine. We use the anterior and the thigh and the posterior part of the thigh, the foot, dorsal and plantar. And we have studied what we all know. Since we work with labs, the functional mobility by time up. Here, we have a semi-static posture through optoelectronic system, SMART. And every time we had this patient being displaced and the alterations shown in terms of balance and support with a smaller and a larger base. Also, we use the distribution of plantar pressure maximum and imbalance semi-static through the platform. This is very important. This is a very enriching assessment. I can assess the feet in different conditions. The fingers. Where are the pressures? Where is the pressure being bigger? Why do our diabetic is so sensible to plantar, especially in the hallux region? But some people also developed in the calcaneus. It's closely related to the posture, and this is what I'm talking about. Usually, the elderly we have this disturbs. If the elderly has osteoporosis, it's always walking to the front, it's curved to the front, maybe also to the side laterally, but it depends on the algic syndromes that he or she has developed. But when I have a diabetic with the plantar pressure, it becomes even more dangerous. And we also have here where I'm stepping more, where I'm not stepping so much, and it gives me the values, the numbers. It will tell me if the elderly are inclined more to the left or to the right when they walk. This patient we used to have this platform, but we suffered from a flood in our region, and I lost the machine because the place was invaded by water. And it's very hard to research in this country because this country does not respect the researchers. So what we have here, a static patient looking to a fixed point, see the positions of the feet, the changes that are shown, gravity center that is displaced, the position. She's stepping on her in her forefoot, and this pointer is very hard to use when we are speaking. The medium foot is not being, the posture is very displaced, is very different. She may suffer of calluses and pain. We don't know. We have to assess. And here we assess the skin sensitivity and reflex through the tensiometer, using all the things that we usually do during physiotherapy. This is our protocol. We assess. Here we have the vibratory platform, lateral. We don't do vertical. This is the sham. We recorded the sound emitted by the platform, and the patient doesn't know it's there. We can turn it on, and the patient will stand there. It's vibrating. It doesn't know, but he believes he's doing it. And this is the position, the posture. We use this position. We use the fair foot, a silicone on the fair foot, a supported silicone, so that the depression is produced in the forefoot. I like to hear your research about your researchers, Danubia, because you use people sitting down, right? Because we don't. We're gonna think about that possibility, but we still don't. Some patients talk about, headache, if they get a little bit dizzy, if they are in this, vibrating like this, standing up. But we use a support behind in the hind foot, the rear foot. This is the sham. This is the position for the platform that I also lost to water. I lost a lot of things because of the water. For you to have the idea what I did, I went to the dean, because it's not my fault if you had this structural problem. And who is going to, repair these machines? This is what I said about how we work. These are the exercises, the assisted exercises, stretching. I brought to you some footages, but here we have a reassessment when we finish the sessions. We have 32 sessions for this protocol, 16 weeks. It's a lot. And I think I won't do it anymore because we have been losses because of the cost, the time of the patient. I cannot give him money to come to the lab. I did it once because I wanted to see how we could do it, but I won't do it anymore. And they ask, how long does it take? Because the university is full of elderly. They are there looking for projects to participate at. This is our material. And here we use a protocol that was published by a bigger group in our lab, and I can say that Professor Tayar was here. Is a great partner that I got from the first time. The first time I came to this congress. This is our protocol. This is the analysis. Again, we assessed 58, we excluded 22, and we end up with 36 in total. These are our results. We have blood flow speed on the right and the left, tibial, anterior and posterior. In here we can see the dorsal arteria, the dorsal artery. When I came here, I lost the marking. But you can see here the 00, right? And the tibial artery and the right, posterior left, the reproduction of the sound, and the control group, no. Here, the time up and go, and we can see the group that you're being very generous to me. 5 minutes. This is before and after of the working group in the platform, the group that used the platform. We had the one thing, important issue here, and I say that when we are talking about it, I usually say we worry a lot about that our results will be statistically important, but we have to think that what's clinically important too. What's the tendency in physiotherapy, in fighting and running after publications? Our bigger interest should be our patients. So if I have a clinical response, this is important in the social side in terms of, attending calls. These social and clinical evidences are important. And these results, excite me because I see that they were important. The sham here, the control. But if we see the intervention comparing to control, it was significant. And after 12 weeks, it's a lot, we had statistically significant intergroup differences that were observed in the improvement of functional mobility for the group with the platform, a decrease in left ankle dorsiflexion, plantar flexion ankle to the sham group. That's what prevents me from stepping like this, This is important for us to be able to prevent changes in terms of feet. And a very important, the increase and pressure and hallux on the right foot. It could be the right or the left, but the important thing is what it represents. My plantar ulcera, my feet conditions, especially because they start to have calluses, they will have to change shoes. And you can look at mine because I am diabetic. I cannot use shoes that will, hurt me the whole day. And we have this clinical decision tree. This, what I have done in terms of money, I won't repeat it. And now we have the SUS telling us that we can have 10 sessions for patients that are we were able to work on them. So why not use these 10 sessions for the vibratory platform? They will have a direct applicability. And we're also working on the immediate effect. I will assess the whole battery. The patient will go through the intervention and then rest 2 hours. Right after, I'm going to reassess him or her to see the changes or the news. This is our lab, Lacertam, kinesiotherapy and manual resources, my email, and thank you very much.
Thank you very much, Professor Maria das Graças. I'd like to invite to the stage Professor Otônio Balarte, who is going to speak about arbitration of metabolical and metabolical syndrome of symbioticas. So I think it's almost after. So I'd like to thank the invitation to be here. It's an honor to be here. So if I'm the last one, the first time I need to be more objective because it's almost lunchtime. It's very interesting what everyone said before. And I would like to say I'm a professor of semiology and nutritionist and obesity and diabetics and hypertension and inflammatory markers have a name metabolic syndrome. But if I have a diabetic and became diabetic hypertense, it's metabolic syndrome? No, it's metabolic complications of diabetes because metabolic syndrome is something doesn't have a name. You have Cushing syndrome is reference to an author, but metabolic syndrome it's not a disease because there is no name. So we need to start with the obesity genesis, and then came all the path. If I have a hypertense person who became a diabetic and starts to be inflammatory, it's complications. It's not a metabolic syndrome. So if the important element we see here is the BMI is epidemiological. So imagine if this BMI is being varies from 18 to 25. If you have 18, you are the minimum. And 3 years ago, and the other year you have 20, and this year you have 24. Is going to see we are outside the metabolic syndrome because the BMI it's normal. But you know how much kilograms you need to gain to increase a point in BMI? You need to each 3 kilograms when on your weight you gain 1 point on BMI. And so if I have a BMI of 18 to take to 25, so I went 21 kilograms. That might be just fat, and it's going to be called normal. I'm excluded from metabolic syndrome. So it's a legal term we have from this classification. Usually used it's the consensus we had is the metabolic syndrome chronicle. It's non-metabolic syndrome and follow-up in evolution. If you imagine the glycemic without eating, but this is unrest. So when you do the exam, sometimes you get up, you are 10 or 12 times, and then you go to the labs on foot, with the bus, with a car, I don't know, and you wait to be attended. This is glycemia on the movement. It's not from the 70 to 99. It's the first cut we need to have. So second, you have to, 3 years ago my glycemia was 75. Okay, and next 2 years it was from 84. I'm still normal, and now I'm on 95. You're going to say I'm normal, yes, but the glycemia that used to be a reflex exam is a post-metabolic because you do a phenesis, and the nutritional is arterial. So it do not dose the arterial one. It's just a phenesis. So if I used to be 75 and now I'm to 84 and then 92, what you say to me that I'm normal? But I already did the math, and every 2 milligrams for deciliters by glycemia, it means 13.4 of glycose circle on your blood, on peripheral nerves. I did this math, and each 2 milligrams is going to repercute here on neurotactile peripheria and endovascular, and of course the microbiota. So when we use metabolic syndrome, this is a wonderful work. It's going to think chronic one. It's a long term. The individual is walking on metabolic syndrome. So I changed a little bit of what he said, and I was a little bit scared when he asked me until that on the next week I used to be treatment. So I was on Santiago, I walked a lot, and then I came back. So I couldn't change my slides to English, so sorry. I do not have the time because I just came back from my trip. And what I've seen from automation, he said, I do not understand a little bit the vibration, the distance of the food and velocity, what is closer, what is afar. And this is really well observed because who used to do like a walking when you are on the joint and then you walk on your normal, right? And who likes to do a trail? You're doing a little fast. And who do peregrination? Who walk? So do not have your feet hurt. Hands like by contemplation. It walks like this. Because the objection is to contemplate the nature and his spirit. And the last is walking. And this is a difference for who walk like this, because I do this a lot. You did everything, and I was the only one who didn't hurt my teeth. I was the last one to get to the place because even the turtle goes through me because I was really slow, but I was there on my time and my backpack on the back. And I going up to the hills, down to the hill, go to the river, 4 days of rain. My clothes was wet, and the turtle was walking through me with no bubbles on my feet. And everyone was hurting their ankles, their legs. And the reason is that being walking slow is that the reason what I listened everything before. So I said before the importance of the metabolic syndrome being prolonged. I have no conflict of interest, so I'm going to call your attention from the microbiome of protection, pathogenics, with skeletal muscle. We have a lot of brain, intestine, brain, lungs, intestine, and then, but the muscles, they are very important. So what I need to tell you here is a technical or the vibration platform. You have a contraction and you also have the relaxing time. So this is what we alternate for a long time. What this is really important who already had a metabolic syndrome. The time of interval of each vibrational stimulation, if it's going to have more or less answer to the exercise, and the glycohemoglobin is really bad because this is you need to analyze the glycohemoglobin alone is just a fake marker. The most important metabolic is the triglycerides from after 10 to 12 hours being without it. So you need to do is when the triglycerides like 10 years, because with much time you stay in the feasting, you need to be even the more time, it needs to be higher. So if you find someone with triglycerides with lower than 100 after 10 hours of fast, this person had less of a glycogen of on the livers, is going to be exhausted lesion, and of course they're not going to have a good approachment of the exercise. So you need to evaluate all of not of markers, any of these tests you try to do. The complication of the diabetics you need to know how to see the control of the metabolic markers of which lower the triglyceride is going to be on the stream of the metabolic, maybe diabetic, exercised, or from the metabolic syndrome. So the importance is the relaxing time. Of course, think about the quality of sleep. We said it a lot because it is really important. The muscle, the nervous system, and relation of it. But I want to show you this. I only have 10 minutes, so I need to explain this. This is a word because you have. One thing is do physical exercise in regular time. You need to understand the vibration technique. It's for the objectives of the Congress, that is the vibration technique. So a good diet is not just the eating, but the prescriptions of probiotics, prebiotics. If you use this adequate technique plus diet and the better increase of the sleep, you improve the sensibility to insulin. Resistance is the disease, is the other thing, and the sensibility of insulin improve. Which more you improve your muscular to the back of the legs, and then you see on this. I see every time when you do in your on your calf, and then and the text is going to evaluate Doppler and vascular because I need to evaluate the calf. Much time you have to being available to see the calf is being hardened, you have the venous system more dilated, being hard and strengthened. It's not the butt, it's just the calf. You need your heart is going to win. You need to work your calf. It's better your butt being a little like a cello, but you have a calf more hardened. It's not so beautiful, but it's physiological. It's being beautiful. But I'm sorry for the. You have your glycemic falling because everyone needs to eat. Everyone needs to go. Better action of antioxidant, increasing of the barrier of the mucus, increase the secretion. So this is why the sleeping is important. The action of the arginine, glutamine, and improvement of perfusion of the blockage of translocation of bacteria, lactase and protease from the microvascularities increasing, and that's why people start to have intolerance of lactose, and it's not primary, it's secondary. And this is when you see secondary lactose, this is diabetes, because the also most common you see real time, since if this glucose, what one is more frequent, and for hyperglycemic it's lactose intolerance. When you born like this, but in the adult or elderly who have intolerance of lactose, even if the glycemic is normal, it used to be diabetic, reduce the abdominal distension, everything is better. And when you do the right vibrational technique, I don't know how it is, but I see that they sell everything. People they almost say by 2 days, like they are a lot of time. And if you put a machine, you put a zap and then internet, people are going to stay there jumping all the time on the platform. But you need to be cautious to this, because people doesn't take care. It's like you stay a lot of time on walking there. You need to then you're going to work on the platform all the time, 28 times contraction. This is a big problem because you need to have a rest. This is something that might happen because everyone can use, you can buy on the Polo shop and other places because you didn't know how to use with the science, so it's a high risk. You have physical effort, the bad techniques, and adequate diet, so you get tired because you have improvement of your effort. And so I got tired even if I eat well. But if I do good exercise and I have good sleep, I have strength in the muscles. So I need to sleep well. So if I eat poorly with exercise that's being badly done, so this is distraction. So if you doesn't sleep well and happen again, the fatigue. So the patients said yesterday I use some medication to be thinner, and then I do exercise to. And doesn't sleep well. What is going to do? It's going to be fatigue because you do not have the glycogen to do the exercise. Or you open your eyes or you open your mouth. You can't do this. You need to talk to someone, you need to rest, and then the rest is the best reestablish of the muscle, metabolically speaking. This is difficult, this concept. So this reference, and thank you everyone and who wants doing my course from nutritionists, from therapists about interpretation of metabolic. I'm here at your disposal, and I took the time. Where's the girl of the time? Thank you, Professor. And now we are going to start our last lecture of the table. So I invite Professor Roberto Lourenço. They're going to say about international guideline for sarcopenia diagnosis, what to expect of the changes of conceptual changes in the last decade.
Good afternoon. Effectively, good afternoon. My friend Antonio was deceiving you because he said that you could leave, but you still have one lecture left. It's a pleasure to be here. Thank you, Danubia, for your invitation, for having inserted me in this schedule at the end. Well, the theme that I'm bringing here is profoundly related to the Congress, but it's not in the focus exactly of what has been said. I am full professor of geriatry at the State University and at PUC, the Catholic University of Rio. This is a summary of what I will say. I will talk about the definitions of sarcopenia in the last 20 centuries and the confusions that it has produced throughout the years in the worldwide. And it gives you the idea where we are. I'm using confusion as my interpretation of it. The ones that have produced this confusion, the intelligentsia, the worldwide intelligentsia, well-known people, very famous people that have interpreted it as a progress, and I don't really see it that way. Basically, sarcopenia, what is it for? That's exactly what was asked in the Congress in Albuquerque, New Mexico in 1988 by Dr. Ivan Hosenberg, and he was invited to this meeting, and he didn't know, didn't know why elderly were losing muscles, But you didn't have a name for this, losing lean mass. But he offered these two names for this, sarcopenia and sarcomalacia. 10 years after, almost that, during a symposium in 1996, he said that sarcopenia was a name that was elected by the international community to mean this loss of muscle in elderly. So we can say that this concept is new. Are you controlling the time? You let me know, right? So in 1996, this name was well defined, sarcopenia. Sarc comes from meat and penia from reduction. What I will say is divided in periods, three basic periods. The first of all, from 1990s to the 2000, the first 10 years of the 2000s, that are marked by the decrease in skeletal muscle mass as the most important feature in defining what sarcopenia is. And how do you measure skeletal muscle mass? This was fundamental throughout these years. Several methods were offered, some considered standards, golden standards, such as RMI, computerized tomography, and some others are tested vis-a-vis, such as bioimpedancy, densimetry, other measurements of anthropometry, and other anthropometric measurements. I don't have time to dig into this. I'm just mentioning them. The fundamental element here to control who is sarcopenic or not, to understand which are the cut indexes, are always the health conditions, the fragilities, incapacities, hospitalizations, falls, fractures, all these adverse events. So these methods have always been tested vis-a-vis with conditions. Muscle mass and physical performance are elements that were also incorporated in sarcopenia, but during these 2 decades, these elements were aggregated. They were concerned about which would be the best way to measure muscle strength or the best way to measure physical performance. A series of tests are performed, but those are additional elements to the skeletal muscle mass, since they're fundamental in the diagnosis of sarcopenia. During the decades, several studies show that associating skeletal muscle mass with these methods, and it's important to observe that these methods would measure lean mass and not skeletal muscle mass, so these are just estimates. All the researchers throughout the 2 decades highlighted that the association force of muscle mass, muscle strength, and physical performance was much more favorable, much more strong to strength and physical performance than muscle mass itself. And some papers saw muscle mass, the way it was measured, as a less important element. And this observation is important because it brings further consequences that I will show you. The series of papers here were produced, obviously, I won't dig into them, but just to say that they existed. There are much more than that, talking about these methods diagnosis of muscle mass reduction and sarcopenia. Obviously, the golden pattern of RMI and tomography, they are not clinically viable unless you have special circumstances. So the search for methods that could be used in clinic has always been very intense. Beam impedance, bioimpedance, DXA, so you can use simple devices with easy training. DEXA, even though they don't have these characteristics in terms of cost and absence of radiation, exposure to radiation, it was also interesting to use. When we go to the second decade, from 2010 to 2019, we arrived to consensus. If you study sarcopenia, you should have probably came across several consensus in this area. Many of them repetitions. One of the first ones was the second, actually, in terms of publications. It was the most important one, maybe, the European consensus of sarcopenia, and the consensus from 2010 and the review in 2019. All these consensus were basically defining sarcopenia as a reduction in skeletal muscle mass associated to reduction in muscle strength and decreasing functionality. Again, using a series of markers that I won't dig into them right now again, with some degree of variation in important aspects. The type of test, the speed of gait, SBBB, for instance, for performance, and the cutting point and the value, the numbers that you use to say that someone presents normal strength and mass and who presents abnormal strength and mass. And I would say that this Eurocentric vision, it's really centered in values found in populations in the European countries. Several times, often these values were very good to select Vikings rather than Latinos. And these are other papers, European and international, Oriental. There are several papers using this consensus. This is maybe the most quoted paper in sarcopenia field. Krujentov was a very active, extremely active person in terms of geriatrics. It's a Spanish. I got to know him in Europe when I was studying geriatrics. And in a certain way, all these people are Europeans that are extremely tied to geriatrics and to the fragility and sarcopenia fields. The definition of this first consensus, they defined the several elements. They divided sarcopenia into phases, pre and post, and it brings to operational and practical issues that they produce also algorithms. They are fantastic but also problematic in terms of selecting patients for measuring this mass. And at that time, me and other researchers in Latin America and Spain, we highlighted the difficulty in using these cutting points that were provided in terms of muscle strength and performance with gait velocity to select who would be chosen to have the mass measured in terms of, measurement of mass as something very hard to do in terms of resources. So this Brazilian study, FIBRA, almost 76% of the people tracked would go to the mass measurement phase. And not only Mexicans, but also the European population, the Spanish, would also select a large number of individuals. In Spain, almost 95% of the individuals would be selected. So why do you use a screening test to select 90% of the population to the next phase? It's, just to spend resources. So these cut points had problems, evidently. So I'm not, go through it again. Some parts of this algorithm were changed, but they kept this problem, which was abandon people who did not have manual pressure strength. So having them as mass, decreased mass, without the alteration of some important patterns would be abandoned. And something more that, perform this treatment, this early treatment before the sickness arrive, before the conditions arrive, and everything that, is connected to sarcopenia. At that time, we were already highlighting this issue together with other researchers such as Bischoff, Ferrari, and others, that there were so many problems in this consensus. I won't detail it, but and now in 2023, Coletta and Phillips, if you were interested in sarcopenia, I recommended to read it, this paper, not only to create opinions, to establish opinion, but they made a review, a very broad review of this consensus. And she creates this timeline with consensus and presents the main elements, mass, strength, and function, with a series of cutting points for all these elements provided by these consensus. It's very interesting to verify the differences between them, how all this evolved, of course. You will see that an element arose at that time. I already have 5 minutes. So, which was SDoc in 2020. SDoc was definitive. And it said how these consensus produced evolution in terms of pathology, but also presented a lot of confusion to the doctor in terms of the investigation, because the doctor would say, how can I investigate sarcopenia? Do I use muscle mass? Which are the cutting points? SDoc arrived to give us something interesting. Of course, this is an acronym, and it cleared up everything. It provided such a radical proposal that we could not keep the previous concept of sarcopenia. So let's keep muscle strength and functionality, and muscle mass estimation should not be included. When SDoc does it, it transforms sarcopenia in other possible frames that have been discussed in the last years, which is fragility. One of the definitions of fragility aggregates muscle mass reduction and functionality reduction. Sarcopenia lost totally this specificity that would mark it, which is the production of this reduced lean mass. Of course, everyone in the community, international community, noticed this confusion. And due to SDoc, in the beginning of the year, we published this editorial in this Brazilian news magazine about geriatrics. We went back to the past to think about sarcopenia as muscle mass reduction in a creative way, resolving measurement issues. The methods that we have are not suitable, or we won't just evolve because this concept won't have any future. So here we have a series of elements that I bring in this editorial that makes so that as doc becomes so radical in terms of sarcopenia and so definitive. I won't detail them, but this is not the end of the history or the story. At the same time, around 5-6 years ago, all the groups, New Zealand, Asia, Europe, America, USA, they were organized in a global initiative, the GLEAV, the Global Leadership Initiative in Sarcopenia. All these groups got together to rethink what they were doing through a new perspective, progressive, and because people think that progress is always ahead, never in the past, but sometimes it's important to give steps backwards and think of what I have done wrong. What have I done wrong? Or I did everything correctly and my mistakes, do not exist, because this is very bad for a researcher, and because we learn a lot with our mistakes, more than when we get things right. But Gleish published a new consensus, and now gathering all groups that produced the consensus before in the first 20 years. This publication dates February 2024, and I don't have more time, I think. Gleish offered that muscle mass, muscle strength, and muscle specific strength were all accepted as components of sarcopenia. Well, muscle mass came back to the game, and it's good. And they place these functions in physical performance as a result, and I like it very much. And the moment I read this article, I offered to be part of the Gleish. No, but now I wasn't before, but now I am. And I read this article. I said, "Oh my God! Now we came back to the correct path." I'm almost finishing. Because I consider that performance should not be only a result. Performance is very important. It's a measure of gravity. I follow it as a gravity measure for sarcopenia. It doesn't have to be included because, as I understand, if you have sarcopenia with reduced muscle mass and strength, you have sarcopenia, but if your physical performance is normal, close to normal, it means it's not so bad, your sarcopenia is not so bad. This is something that has to be tested, of course. I wouldn't risk to affirm this without any worries. Gleish formed 3 groups of work to study mass, to review completely everything that is being done, worried about verifying new markers, one to force and another to the results. There's still a lot to be done in terms of research, muscle mass. Now we use heavy water, and maybe this is the one that presents more possibilities for the future. And from in terms of cutting points, we are developing other techniques. My group in Latin America now we are worried about developing these curves and anthropometric curves, not to have just one standard for an old person, a 6-year-old person, and an 80-year-old person. I am 68, so I can say that I am old. So all people with 60-year-old are definitely different from 80-year-old elderly. You cannot use the same cutting point, 3 kilograms force for men and 20 for women. This does not work. This classification will be wrong. And there's something important is to develop a more solid theoretical basis encompassing fragility and sarcopenia, but also new capacity, new concepts of capacity or physical capacity and resilience that were proposed by the OMG. And this is for people who are working in clinical practice, because otherwise we start to use wrong ways to make our diagnosis. Thank you. Thank you to all the lecturers for this excellent round table. Now, since we are kind of late, we're gonna have a shorter time for discussion. So I invite all the lecturers of this round table for our table.
So we have only 5 minutes for discussion, for a Q&A. Anyone has a question? So, Danubia, I would like to make a question. You have been working with various protocols, also by metabolic syndrome and obesity. In each, there's any you have a better result, or all of them are. There's a lot of distinction between the results. So what we've been realizing is that we had the improvement protocol by muscle strengthening and the other by bottle corporeal. We couldn't see all the results, but what it seems is that we cannot find what the just one result is that the platform is good by every condition. So we can use improvement for neurochemical or by muscle strengthening. They're be different, but like for example, the metabolic syndrome, you see these sessions, you could improve the body composition also. In the other one, we did have the sample we had. We could improve the same parameters. So we are still studying the sample we had from the group. We need to compose and analyze. And from the obesity, we also have little less than the half of the obesity group. Some of them suggest some results, but we couldn't close for a fact. But what we did observe is what we could not say a protocol that improve everything. We may have some questions that could improve everything, but we probably would have a specificity from each protocol to improve what we aim to do. So thank you. We have a question here from Dr. Paulo. So this question fits to Danubia and also to Professor. But in reality, I think it would be extremely interesting what you said, what is cause and effect in the metabolic syndrome. But the same way, I think that this today show us more that we clearly see the certainty, the precision medicine, like we say today, the effects of the vibratory platform. But we didn't have so many effects. How this happened? To study how we've been discussing usually. So the question I do to all of you is biomarkers in relation to process of what you could get to the results you aiming or in how they get to, and to professor about the meta-inflammation inside the metabolic syndrome and what is cause and effect. Thank you. So this is exactly what you put in. We've been evolving the search and the comprehension, and we have not only the deficiency on the group, but also the scientific community as a whole. And we see on the studies use not just about the muscle strength, but the mechanisms that is being involved. We have some action mechanisms relation to bioreceptors and biopeptides and proteins and other things. In the obesity project we could see inflammatory markers, thermogenin and other things that we have a rich research that we couldn't do it to the end because we didn't have the money to do, but the obesity project we could. So we have all the sample we collected in a linear research we're going to analyze now, and we have more than 100,000 kits, so we could answer more and find those mechanisms. And like you said, precision medicine is the next step that we intend to investigate, so we could find and understand better this phenomenon that happens. It's not just a macro vision. Okay, you improve the functionality, but you have the comprehension of what is clinical relevant in this condition of the patient, but we also are still needs to comprehend the mechanisms that are involved in, and so I do not have the answer yet for you. So, Paulo, so the cause and effect. When you talk about the biology, you depends who was being said first, who was being diagnosed first, and who was indicted first. So the metabolic syndrome is the M. There's 5 points. So 5 metabolic points is the pace, you have the weight, an overweight, obesity, in other glycose, diabetic, in the other hypertension, the other inflammation, and then you have the 5 points, the letter M. So I have a target, the obesity, you have the purple, yellow, red, and green, you have all these parameters. Obesity, you have the target, it's in the normal IBM, so you see the overweight like on yellow, and the red is the obese. So we have the glycemia of 50 to 99 is normal, 99 from 110. So I start to draw the person and see which point and see if it's metabolical and obesity, what is the consequence from the disease, or is the syndrome itself. So what I see is more difficult is to diagnose the metabolic syndrome, to say what came first, the head to nurse you and guide you through what you give your I don't know which language I'm saying. I got confusing, so I was away for a long time. So what happened is, what we see first, diabetes was diagnosed by concepts. We have like 10 years of being late, because diabetes is always being late on the concepts, and hypertension most of the time is silent. You just see when it's on the peak, and obesity, because you see on the beginning, because everyone see when the person starts to gain weight, or when the person is more round, or with the clothes stretching a little bit. So hypertension, in my opinion, is everything is already science. So you need to see. So information is mixed with a lot of things. So you do not have the information. So you need to see the history. Since when you see the difference on your body composition, you gain weight. Everything you're going fast is the visceral fat, and when you lose fast is the skeletal muscles. Everything you lose fast is muscle you lose fast and you takes long to get. And this is, you cannot avoid it. How much weight of you gain, you need to know the velocity you're gaining this weight or losing it. You may win it 15 kilos in 3 months. You have 5 in one and another and then the other. So I had 5 in 2 months or 10 in the last month. Or I have 10 months in the 2 months and then 5 now. It's 15 kilos in 3 months, but it's real difficult conditions. Remember when you have on your, you only see the thin masses, you see the fat or muscles you weigh and the fat you measure. You do not need to have it be measuring every time. It's better to have a staple to measurement on your if I'm dexter, you're going to be on the left, right. You have an effect like this. So the history of the clinical, it's more important who begins first and who came after the metabolic syndrome or complications from multi-metabolic syndromes. So thank you. So the last question is? Danube Professor, good afternoon. I'd like to know the interaction between the patient and mechanical legislation. There is any study and been using from the interaction from the platform on the vibrational platform with the ventilation and how it stays this patient. So I only know on literature what I showed this on my events. We only had as my follow-up, I didn't investigate it for a long time, so we only see what is available and what is not, what it altered, what it was a characteristics. So yes, it didn't put effective. I don't know if they could the study of viability, if it gives a follow-up on the study to see the effects on the long term. This article was not so new, and up to now he didn't do anything, so I don't know if they are talking about anything. We have the intention to do this study sometimes because the hospital provided us a space, but we couldn't go there to start the study. So I don't know if we're going to do a follow-up of this study. We are going to talk only about viability and to see if we alter the parameters negative or a positive way. It was okay, did not alter, and this publication is the only one that I hadn't know, so I do not have any answer to give you now. So I'd like to thank all the congressmen here. So I'd like to give you the certificate. I like just to give you a little time. We not gonna take you to go to the lunchbox. They're going to give you so you could have a follow up to the cannabis lecture.
Boa tarde a todos, né? Para a palestra satélite.
Good afternoon all. For the satellite lecture, we have the members and professors, student members and professors here. Let's start the lecture. Professor Dr. Sandro Gago. Thank you, Andrea. Good afternoon, all of you. It's almost impossible mission to keep, the attention of all of you, for it is such an interesting issue during the lunch break. So the objective today is to talk about medical cannabis, the viability, and to bring a concept that will allow us to have a new perspective, of an integrative perspective. And you will understand why further on in my lecture. Let's go on. Not to be redundant, but the theme is clinical applicability and viability for the use of cannabidiol. It's a concept from SEC, the endocannabinoid system. It's important to have at least a minimal understanding of these concepts, from which we will trace our guidelines about our everyday living in our labs, in our offices. It's a regulatory system, vital and present in all human beings, with a fundamental role in regulating a series of physiological, pathological processes in the human body. We have to understand about these two receptors of cannabinoids, CB1 and CB2, and their connectors are widely distributed in our organism, modulating several functions, including neural development. Our focus is in the comprehension. I think these are very interesting concepts. Endocannabinoids, for instance, are molecules that all of us produce in our bodies. And cannabinoids like molecules, it's a new concept, but we have all had access to these molecules. For instance, lemon, mango, all of these fruits and elements have this molecule, and we have to to overcome our prejudice. Phytocannabinoids, components deriving from plants found in cannabis, with a high potential, therapeutical potential, and synthetic cannabinoids, molecules created in labs to imitate the effects of the cannabinoids. This comprehension, again, it's very important for us to explore all the therapeutical potentials and interactions between this cannabinoid system and our lives, to offer more effective and personalized, customized treatments to our patients. I work with athletes, high performance athletes, and normal regular athletes, and it's important how we can customize our treatments to all patients, and regarding sickness and dysfunctions, and how to improve the quality of life of our patients. As I said before, it's so important to take a look at it from a different perspective. We have these two receptors, CB1 and CB2, and this image illustrates where these receptors are distributed in our organism. So we're talking about central nervous system, hippocamp, immunological system, gastrointestinal, physiological functions, metabolic regulation, appetite, pain, movement, humor, bone growth. This image is in my head 24 hours a day. When I look at a patient, when I receive a diagnosis and create my treatment, it makes me understand better. Understand how can I can create better prescriptions to the patients. The growth tendency. Obviously, in Brazil, Brazil is very important nowadays in the worldwide panorama, because it was the first country to create a rigid framework when it comes to Anvisa, of course, to the medical use of the cannabinoids. And Brazil, it's the country with the better regulation framework and management of the medical cannabis. In terms of import, numbers are incredible. They are over 93% in 12 months. The Anvisa, the agency, forbid the import of the plant in nature due to a series of reasons that I won't mention here. But again, there is this perspective towards prescription of the product. The number, it's absurd. 2023. This is out of date, but this is very huge. This is the import number. This is what Anvisa delivers to us when we have to authorize the patient to buy the product abroad. I brought a clinic case for us to understand this new perspective towards the condition of offering cannabis to all our patients. And my vision is always towards an integrative practice. Of course, you have the vision of the disease. We also have to speak about these pathologies that were the first ones for which the cannabis was used, epilepsy, for instance. But we also have to use an integrative perspective towards our patients that are practicing physical activities, and for some reason they ask us to improve their performance. This example from last week, I have this patient, a high performance patient, 38 years old, 80 kilos, 1 meter 76. His black belt in jiu-jitsu and started marathon, but he has fibromyalgia and also showed anxiety situation and also insomnia. He was already taking medicines, and his problem, his pain, was the lack of sleep. He couldn't sleep. He didn't know if he was due to anxiety. He wasn't able to practice his physical activities and have a better performance. This was what he told me. He was suffering a lot with secondary effects because he understood that he was increasing the dosage of his medicines, and he couldn't find the perfect dosage, to regulate his conditions. So, of course, we look at the market in this case too. I particularly use full spectrum cannabinoids because this oil contains all the cannabinoids. And the CBD that I use is 3,000 because it has all the cannabinoids that I need. So I used the regular day Allegra training. I prescribed 8 drops 3 times a day, and the day he does not practice, when he's not practicing his physical activities. And when he is practicing, I have this attack dosage, 10 drops during the morning, and thinking about supplementations, also 6 drops pre-training and 6 drops post-training. And how did I arrive to this conclusion? Through observation. We are talking about a phytofarm that has a half-life of 8 hours approximately. This is a high-performance athlete, and cannabis is hypophilic, so we have this issue, and through this protocol I established an improvement in his performance as well as improved his sleep. And this was his answer, his feedback. In less than 1 week, this was so recent, October 14th, he had ran of 36 and went to 58, 2 hours and 8 and 2 hours and 15. This guy calls me every 45 minutes because he's anxious a little bit, but his sleep is fantastic. He also wrote to me talking about this improvement in his sleep. He was really happy with the treatment. So we know that it's a potential anti-inflammatory, a potential modulator. He's very good at inducing the sleep. So we have to know how to use these basic concepts to our patients. I don't have so much time right now, but just, to let you know my perception and the perception of the authors regarding cannabis in sports. Obviously saying about different concepts, but this is very important. This anti-doping world agency controlling the forbidden substances already authorizes in some states and countries the use of cannabis. They can also buy it from other countries and states as supplements. So this is very new that we have to start to use in our daily lives. It's a very good way of supplementing. It's a good supplementation, and I'm very fond of it. And we have been seeing this growth in using it and studying it. And I'm bringing all the references that we're using. So going back to changes in humor and mental activity, we also talk about the cognitive function. It's very important. It keeps the homeostasis. It participates in processes that in the brain, in brain activities. And when I started to prescribe cannabis, I based myself in a very specific concept. It's a very strong anti-inflammatory, and we understand that our diseases start like this. So if it's a very strong anti-inflammatory, I have to use it, right? So we should look at this basic concept of cannabis, as I said before, so that we can understand how to better prescribe it. He's a very strong painkiller, and you know that high performance athletes have a lot of pain. I also have, and I realized also that this pain was coming from, my exercises and also emotional issues that I have. I am 58 years old. I train a lot in high performance after cannabis because I really understood how to use this implementation in pre-training and post-training. Quality of sleep, it's incredible. It helps a lot. And when we have this improvement, and we are talking about REM sleep and the quality of our main hormones. This is super important. If we have an improvement in sleep, we improve our main hormones. For men, testosterone, inflammation, and oxidative stress. Since I know one of the main functions of cannabis is become a strong anti-inflammatory, I should actually use it. And all the athletes have to start this inflammatory process to gain in performance, in muscle, or to achieve their goals. And this inflammation suffers a very high tension, and by using cannabis, we can regulate it naturally. This is a very nice example describing how you can use a high dosage to achieve regulation in glucocorticoids and cortisol in humans and a good inflammatory response for injuries. And we understand that this drug is safe. My time is over. We arrived to our conclusion based in information gathered and all the evidences to central nervous system, anticonvulsive and antiemetic, controlling spasms, controlling glaucoma. We can see thus that medical cannabis become effective and safe as a potent helper and supporter to therapeutic performance and to improvement of therapeutic performance, helping us having a customized look at our patients.
Good afternoon. Here is the hard part. We start to visualize economics, the cannabis. Anyone here is from Avisa, it's the FDA from Brazil. Any student from the UERJ. My name is Renazito. Please put the conclusion. We have the improvement of cannabis and the how to use and how much we can use for medication. And Visa had the analysis of medication with the
working with physical education would be here with me to talk about measurement of measurements. I am Dr. Professor Luciana Pires. I'm a nutritionist. I have a master and PhD degrees in physiology. I work in the physical education department. I have a PhD degree in promotion of health. And I work with obesity, focusing in severe obesity with an interdisciplinary approach for people who were not elected for bariatric surgery and can benefit from some care in the contact with a multidisciplinary team. We have a group that work with people with fibromyalgia and obesity that lack services in terms of public health system. And we offer nutritional and training exercises, and usually use the 5 elements described for body composition to arrive to a whole body composition. So we're gonna talk about adiposits and why. Because when we think about measurements and equations, everything that has been offered throughout the years in terms of anthropometric measurements, they divided it into 2 stages. I'm happy here because Roberto Lourenço talked about it perfectly. It advanced much of what I will discuss here about the validity of what we use as measurement, especially when we think about chronic disease, chronic conditions. We're going to look at references, how they were created, some of old and we're not updated, especially for us in the lab. We work with obesity. It's totally out of date. Danubia talked about it brilliantly, about IMC, which is extremely fragile, but we use it because it's what's easier to be measured and somehow supports us for our study of the body, the whole body. Today, when we look at this body, we divide it into fat-free mass and fat mass. We have the essential part, which is necessary to protect our organs, but the non-essential that bothers us the most. Without leaving behind all these parts, what we expect that will compose our body. And this is what we use to talk about health. We can estimate these values, these numbers, as excessive, normal, or harmful, but we have some methods to use. We have direct methods. We have also indirect methods to estimate, more sophisticated ones. Bioelectrical impedance, I think Antonio Claudio mentioned it. It's relatively simple, and it's not really sophisticated or expensive. And the estimates by anthropometry. They divide the body into two components. We're gonna call your attention to what we have in the health system, the public health system. What do we have there that we could use as a tool to assess the composition of the body? And how can I verify the limitations that it offers with respect to the population we are treating? We are working daily with this assessment process, and we ask ourselves, to which extent does it give to me a good parameter, a good support for my intervention? So we work with exercises, and everybody, I think, mentioned that one of the ways we can improve health is food, physical exercises, sleep, and mental health. But even when we think of chronic conditions, promote exercising is something that must be done with safety, because we're talking about the cardiorespiratory trait. And this is one of the things that we try to deal with to improve people's lives. It's a concern that we have every day, because we need to offer health in a very safe way. And I'm going to go through the measurement tools. We have the basic tools, the balance, the adipometer. But for some populations, the tape and all of these are not enough. These tools that we have shown you, they are sophisticated. I'm going to start with them. This is the AXA we have in the State University. And initially in 2018, when I started to work with obese, I started to use DAXA, and problems started to arise. Look at the arm. It is left out, right? And this is undoubtedly, this is what is shorter than MC with respect to what I've received today. This is really embarrassing to the patient to go there, to go through an exam and then not fit in the machine. This is embarrassing, and when you compare to the final result, it's not, reliable. We stopped using it. For this population that we assist, severe obesity, this is not something, DEXA is not something that we can use. Bioimpedance. This is the platform that we use in collaboration with Lavimpi. This platform is very small for them. Amongst the requirements for us to use, we have to keep the limbs separated, and this is not possible. This is one of our limitations. We can use a treadopolar, and obviously the obtaining this angle would be important because it talks about the cell health, but there is not a reference, a pattern that can be used for these specific population of severe obese patients. Skin folds, not possible with the population that we work with. Adipometers are small. They don't open up enough for us to, capture this fat percentage of these bodies. Perimetry, is it possible to perform? Yes, but we have several limitations too. I think Lara can talk about it a little bit. Good afternoon. I'm Lara. I'm a professor of physical education, graduated from UERJ. I work at the laboratory of obesity assistance. We have some assessment criteria and some limitations. Perimetry is the assessment performed inside a lab, but it also shows some limitations. We have mentioned and showed some measurements that we do in lab, which neck circumference, and we use some parts of the neck. It's perpendicular to the longer axis of the neck, and I'm gonna shortly go into them. The assessed is relaxed with arms in a normal position, relaxed, and the head is positioned in the according to the Frankfurt line. And this protocol is the standard, international standard that we know, and we follow it. The waist circumference, we get the lowest costal edge and the top of the iliac crest, the lowest costal edge and the top of the iliac crest, perpendicular to the long axis of the trunk. An abdominal circumference, it is performed above the umbilical scar, also perpendicular to the long axis of the torso. So both circumferences are the assessed is standing up, relaxed with arms in a normal position, and the hip circumference is taken by measuring the largest posterior protuberance of the buttocks perpendicular to the long axis of the trunk. The assessed, the image has the assessed with the arms crossed, but the arms should be relaxed in a normal position, the legs together and feet together. In mid-thigh circumference, we measure thigh circumference at the mid-tibial lateral trochanter side, perpendicular to its long axis of the thigh itself. And this mid-thigh circumference, the assessed is in a relaxed position with relaxed arms besides the body, and legs should be separated, and the weight is equally distributed by the legs. And why these measurements? Because we're always looking for risks. If I want to implement a proposal, I have to know the patient. What is the risk that she is showing to me? So what does the literature say about perimetry that could, help me approach the risk? So hip circumference, mid-thigh, and most recently we have introduced the neck circumference. We will understand why, because we're going to explain it a little later. It has been a measurement that will providing a good response to us of easy acquisition and provides for a risk assessment to cardiometabolic conditions that might be interesting to assess. And we have used IMC standard designed by the OMS. Yeah. And we are not being able to work with it now, so we work with the index of the Bariatric American Society and not with the WHO anymore, because the population that we received here in our lab, they are here around this IMCs here. They are young. They still have some active part of their lives, and they're desperate for some sort of care. Waiting lines for surgery in the public health system are long, and they are desperate for some treatment. So what can I use when I have this type of patient to be taken care of? And when we look to the literature, this is critics. That's my critics to literature, is that they put everyone in the same group. And for me, for us who work with obesity, it's clear that this individual here is very different from this one. Limitations that this one here has, it's like life limitation, It's absolutely different from this one. You cannot put everyone in the same group, These metabolic characteristics are super different from this one. Adaptations, pathologic adaptations coming from these changes imposed by the fat, they made so that the sickness, this condition is different from that one above. So when we look in the literature, everyone is put together in the same group, except for some articles that talk about bariatric specifically. So how do I approach properly these patients? We're still talking about body composition assessment, all the proposals that are guided, that are directed to the obese individual, but they are not good for us. And this is something that we have been using, the neck circumference, which is something very interesting and has been providing us a significant response. Most of them have sleep conditions, sleep disorders, because the level of fat in the neck blocks the air, somehow blocks the flow of air, decreases the respiratory profile of this individual, damaging the pulmonary function. And more than that, so many papers showing how the changes in these measurements interfere and are associated positively with changes in the metabolism. So this is something that is becoming our solution for us. This is Laura and Vanessa. Use these images for us to represent the differences in terms of IMC. You're talking about the 3 kilos that were mentioned before by Professor Antonio Carlos in terms of energetic consumption. Look at how different. IMC 36, IMC 37, IMC 47, 42. This is a morbid obesity. And this is super obesity, according to this American Academy. 57 to 52. They are barefoot because when we perform the test, we use the markers for the gait, and then we assess the gait cinematics because it changes from individual to the other. Super obesity, 76. Everything is altered because of this fat. This is one that is totally different, losing the possibility, the functions, the daily functions. And we can even imagine. So within the limitations, one of these is a balance, weighting scale that will weight this person. We were able to buy it through funds from a call that we won. It weighs more than 200 kilos. It is, has sensitivity for body mass greater than 200 kilos. This is a sort of patient that cannot use our regular toilet bowl anymore. And the prevention of risks is very hard, and also the assessment of this patient. So Lara can talk about specifically about the limitations she found. When we receive and welcome these patients in our lab, when we perform perimetry and assessment, one of the limitations we found is clothing. We know that for us to assess through perimetry the individual, this patient, women should be using a bikini and men should be wearing a swimming trunk, and we do not receive them like this. The majority come with a lot of clothing for us or unsuitable clothing, as we see in this picture. This patient, she's using a long t-shirt and leggings are not good because they compress this part of the body, and it interferes in our assessment. It's slippery too when we try to place the tape for the measure. And also the embarrassing situation. They are all embarrassed and uncomfortable. So besides having to assess, we have to, welcome, try to deal in a very comfortable way with the person, especially if they are women. They prefer female assessors too. And another limitation is that since we follow this international standard from ISAC, they don't have any protocol of how to perform perimetry in these individuals with obesity. So when we are following this standard guideline, we see a healthy standard body in the first picture. When we want to perform the hip circumference, we don't have a standard hip. We have these folds that we cannot, where we cannot place the tape. And we are not able to do much. We ask the person to, adjust the fold. We don't have this described in literature. So we do what we can. Here in our video, sometimes the embarrassment, me alone, I'm not able to, use the tape around the hip, the waist. The patient helps me in a very subtle way, sometimes unnoticed, for me to, use the tape in this patient, trying to adapt and finding a way, a not so embarrassing way, She doesn't notice what is happening. You know how we're, trying to use a tape, and this waist here could be with could have a lot of folds. And how do you place the tape here regarding the folds? And we don't have anything in the literature describing this. So what's the validity of my measurement in this case? Another limitation, as I said, the unsuitable clothing. Since she's using leggings, she's compressing a part of the body, and when the belly is overcoming the waist, so how can you do it? Can you ask the person to lift the belly? This is so embarrassing, And since the belly is falling down because of the fat, the circumference, the abdominal circumference, according to the protocol, says it has to be in the umbilical scar. But this belly falls down, so how we end up by measuring, passing through the umbilical scar. It's not perpendicular to the dorsal axis. Is it correct? No, we don't know because there's nothing in literature saying about it. We've been discussing about it a lot, thinking about the security of our interventions and our proposals to these patients, and the best way to assess this group of people, because we are here for this. We are working on these protocols, and we're looking into other sources too. What do we have in the past or in other areas that could, be used and give us, support in terms of their cardiometabolic and respiratory function? We have been used for some time with more than 120 people. The 6-minute walk test, which is a widely used test worldwide to assess the cardiorespiratory function. Some of them just can't even start the test because they arrive this person arrived to me, and then we go to the Rayage campus, which is a circular. Oh my God. Because it has to stop and come back, and then it interferes because it's a non-stop track, and the person can walk what she or he can during the 6 minutes. This is what Vanessa is presenting in Portugal today. So the higher the IMC, the smaller the walking time, the duration of the walking. So my individuals, they are super obese. They walk around those 257 meters. And when we used all the protocols assessing respiratory conditions, they say they are in favor of pulmonary transplantation. They have to be bigger or higher than 400, otherwise it's risky. So it's between 350 and 400, and our patients in this level, they were 250. We perform other tests to see if this number would change. So an alert so that we can truly look at a better way to assess these people and intervene. Another test that we have been using is sit and stand test, which is also good. giving us a good response in terms of cardiorespiratory trait and function. Although they have so much muscle, if they have this muscle, so much muscle in their lower limbs because they are, lifting 200 kilos, but these muscles are not efficient. So we are doing this sit and stand tests, and they have results that are lower than the expected. And also we have the unipodal static balance test because they change the way they place the feet on the floor. I've already taken pictures of that, pictures of the professor who brought the equipment that mark the strength of the gait, but they lose the curve, this population, to get a better base of balance. In the image, the correct is to stay here together with the other leg, and they can never do it, they never get it. So this is what we're aiming, this is what we're bringing to this forum, all these problems that are coming out in our past that we've been working in the best way we can, and looking in other areas looking for other protocols that are described and can support and give us support in creating assessment processes that are for a population that is not receiving proper treatment because they don't have the basics, and we could treat the best way we can. These are our references, and thank you very much.
Thank you, Professor Luciane. Anyone has a question? No, so I would like to thank you once more for your participation, for this important subject. We need to think about these patterns, and just to leave a question. What you tell you a little bit for us about the importance of relation to anthropometry and the anthropometry characteristics in relation to the importance that you see that just one or the other could give you the importance to understand the patients to relate to this index is important or not. Thank you. So what I believe is that we have reached more another world post-COVID, because a lot of things change and the metabolic profile we are not recognizing like it is before. So obesity, especially the severe obesity, is so multifactorial, and any type of evaluation would be physical or anthropometric, couldn't disconsider the relations of this individual in this state. So there's another purpose that are emerging, that we could consider the BMI, even the Brazilian society is giving a purpose, considering the biggest weight that the person heated, and then the other factors from the weight gain, and we are getting to one evaluation that would be able to predict the problem and the comorbidities. We could see the risks involving. We need to see is a multifactorial look. And we need to know what best fits to our patients. Thank you. And before I take to the table, I would like to thank you everyone for the participation here for us today. And Sam's Club is here outside in Cristina, so you could use it. And who gave it is going to win this present. Pisca, he is here outside giving us support for us in these 3 days, and we're going to take a picture. I'd like to invite everyone to go there and let's take a picture. Where's the gift from the professor? needs to give his gift for her.
Boa tarde.
Good afternoon. Let's stay here after the lunch. Now let's begin with the roundtable number 5, technological innovations in diagnosis and therapeutics. And we are going to start with the clinical demographic and criteria and applications from Professor. So I will start now. I'm Adalito Seixas. I'm professor at Porto. If you want to know more about me, there's a QR code here. This is my presentation. The tomography is an image. You do not need the contact with the patients to have the temperature from the pelvis, and in the end the technology is to capture the radiation that is emitted by the skin and permit us to know what's the temperature of the surface. What's the advantage is the fact that there's no contrast method, and what I tend to show us in this presentation is some concepts that are important in the applicability of these techniques. And what is really important here is the criteria of application. The only way we can do this and have important data is take care with the protocol. In the end, what I tend to do is in the end of the lecture, you could have an opinion, more informed about what is the thermography and what is adequate to your context or not. If you want to discuss a little bit, temperature is being utilized on the health more than 500 years, and we could use it to evaluate the disease, and numbers of scientists contribute to what we should know now what is and what isn't the measurement of the temperature. And Galileo was the first one to create a thermometer, and it wasn't a good instrument, but it was important. And Fahrenheit created a measurement scale that we do not use it here. Celsius created one that we sometimes real wrong. We use it as Celsius degrees, but this scale of Celsius said that water takes to ebullition on 0 degrees and 100 degrees. They frosted, but then after Linnaeus said it didn't make sense, so what is going to frost it at 0 degrees, and then the centigrades that we use now, the SI unities is Kelvin who created, but we almost didn't use it. Is mostly the centigrades. It's what we call is the absolute zero, and what we call 43.5 centigrade degrees. What we know as the absolute zero is this value. Carl Underwood in 1950 was the biggest clinical scientist who came with thousands of patients were being treated with disease related to temperature, and some it's not true. What we call it to keep doing the same way. So these pioneers, in some way, they. So everybody has temperature superior to absolute zero, emits radiation. There's energy. So this energy, there's a length of the light and the spectrum of these characteristics, and there's a lot of features that we see that we capture this energy. The most of this unity we see related to anatomy, like the structure, and we need to take this sometimes physiography. We look to the demographic image. We do not have the anatomical information, but we had others. So thermographic chamber, it's complex, so I won't get to detail, but there's a lot of engineering technology, but it's a simple way. What it emits is a look to a surface of the body, and after you're going to transmit the information, and what you see is a representation of the thermal map of the skin, what we're starting to analyze. And you see the values of the degrees, and then you see radiations. It's almost perfect because when is the maximum value, it's 1. And you can have some certainty of what we're seeing there. The features of the thermographic cameras is we have some, of course sometimes I have on my cell phone, it's so small, but in clinical context it's not there, but we evolve a lot and reduce the size and reduce the price. For us it's important, it's nice because it's not so cheap. What is the specifications we need to have to the system? We need to combine so we could have a tool that could work, like for the amplitude of the temperature, where the camera can work, and there's a camera that could see less 20 to 120 degrees, so we can work on clinical practice. And the thermosensitivity, you see how much value you could see in a camera, and the value of 0.5 degrees up to 30 degrees, because most of them they're being studied of specific features. And also the spatial resolution, the number of pixels the image is going to have, and you need to have at least the resolution of 320 by 240 pixels. Then accuracy, the potential, the margin of certainty that you're going to have is an instrument. Never gives you value. There is a fact. You need to have a margin of error, so you have degree of certainty of 2% of reading, but this is as acceptable. But for beyond of that, you need to fulfill all the recommendations, the security to the transmission of the data, and you need to have all this care with this data. So you look this, you can imagine the difference of the temperature of the spatial organization of the person. Other thing that's really important is the notion that we should have that when we're going to evaluate the conditions of our camera, because as any other tool we have, it needs to be calibrated so we can use this tool we could do to calibrate. It's a black body, and the reference temperature we do should have the same temperature that the camera is going to show us. It's the degree 1 and almost new. So if the black body is on 30 degrees, the camera should show the 30 degrees. So we need to understand that this uncertainty is not the same in whole amplitude. So what I need to do is start to roll the black body for different temperature and trying to show what they are getting in the camera. You have this analysis. It's able to see what the camera is measuring and what it shouldn't measure. And to see in this camera, what it between 25 and 30, you have a bias. They should be, but you see is more in the higher degree and the less degree have a bigger difference. And then we start to know our camera. But when you have this uncertainty, you want to have a value. There's absolute no decisions. You see the difference between points and following the variation of temperature for the time. So in the end, what we have is the skin temperature on the surface. It depends on the blood flow, but it's not just about it. It depends from the interaction with the complex relations between the tissue, inner tissue, metabolic activity, and vascularization, and how the nervous system, autonomous nervous system, have the function of. We have a thermal physiology. You keep your temperature constant around, independent to the variation we have in the exterior. Our body is organized on 2 compartments. Is a central one. When we have the organs, you need to keep and protect from this variation of temperature, and then you have the external and peripheral part of the bodies that varies more. How much the core keeps this temperature, permit the losing the heat and then keeping the heat. So we lose temperature with numbers of ways. The camera show us the heat that is losing by radiation, and when we have this radiation, we have other paths to avoid. By convection, we can be in front of a fount of circulation of air and the conduction font, and by evaporation, like you have an exercise, then you stand and then you lose the temperature by this path. And the other thing is to being really well kept and described data through the time, and you need to conduct these expositions. You trying to do the evaluation sitting up or laying down, so it's not the same thing. The area of losing temperature is different. And we work as a system of feedback. We have hypothalamus. They're going to define the value is going to be, and you're going to balance the temperature on the periphery, and then you're going to keep the temperature or losing the temperature, and then you have a constriction or a vasodilatation, and then the venous arteries, you're seeing the fingers of the hand and some areas of the face. You have more alterations of temperature, and we can do tomography who is statics and dynamic. I prefer to use the dynamics because we can evaluate better as an answer or as a stressor, and the stressor could be a mechanical like exercise, or thermical like you put a hand inside a cup with water, and or a chemical I do exercise like a thermical stressor as a way of challenging the variation of temperature of the skin. Variation of this every time is going to be more attention, being more compatible with the surface of the skin. We could use it. You can do tomography as a way of diagnosis or as a way of screening, is a fast method of evaluation, also to see the effects of monitoring like an exercise or a physiotherapy technique. The Renault syndrome is have vasospasm in little faces on the hands and the feet. Is a diagnosis who can be done really easy on tomography. So you need to have a gradient. There's difference between the fingers and the palm of your hand. It's a stress test, and just put your hand on water at 20 degrees, like environment temperature, and the water blocks the emission of radiation. And through the time of the value of the gradient, you can see it have Renault or didn't have a Renault in the pack with other disease. A recent article tried to diagnose kids with autism and to see if there's difference in tomography. You see a difference with audiovisual, like you have the feelings of happiness, anger, and sadness, and then you evaluate this feelings, how have the temperature in the face, and you got some difference, and it's really interesting, but it's just the beginning because you need more kids to evaluate really, but you have some data. Another area they use it a lot, and we put it is because reconstructive surgery, when you use another part of the skin, so you could perforate it. So usually we try to evaluate the sign with the artery or in the flex. And there's when the tomography could be useful. When you Norwegian, they use it a lot. It's like a little ventilation test, is a stress test. You see a little bit, and then you put reburning of the skin, and you see where there's the arteria who had a problem and the other that doesn't, and then you started to mapping where is the best way to see the arteria. And at the end of like 3 minutes, it started to have the outspots, so you can see the arteries who keeps to the surface of the skin, and then you can improve the process of taking or decision taking. Another area we use it a lot is evaluation of peripheral arterial disease. in the end, feet have three big arteries, and all of them started to assume a few angiosomes. And what we are doing is to do a stress test by cold to provoke heating, and then reheating these areas. And we usually see this pattern. We have three images: the before the test, immediately after the test, and 5 minutes after, if person doesn't have a disease. And when the person has the disease here in the bottom, you see it's totally different. But we could notice that when it gets to a certain value, we have a heating. Patients with diabetics doesn't have arterial disease. Other situations could be interesting. Use the thermography as a prevention on elbow tendinopathy, the presence of outer spots with some places in the arms, and after the treatment it's gone. So every time is important, every time the temperature is important on the indication of process of intervention. This could be used. Another evaluation that was really interesting to me, there was a work that was done by a Brazilian who had results that during the work, the athletes with thermography, they could reduce 64% of the lesion of muscle lesions. And what's the problem? You have other quotes and the production of the data, and there's no more articles after because it's difficult to obtain the data. You need more. I'll say, okay, you have the thermography, then I can prevent muscular injuries. No, I need more information so I can do this. It's just one information, but since 2017, there is no other one that did something similar. Every method needs to be challenged. Like thermography, you have documents have a consensus, and the patients were described every factor that were important to do. To report when we're trying to write a scientific article. And what is the source of uncertainty when you are evaluating is the thermographical images, but in the end is the standardization is the key of the protocol. And I know it's my end of a time, so we're going to be faster now. You need to turn on the camera 30 minutes before so they could be stabilized, so there's no problem during the test. So we need to know our instrument so we could turn on 30 minutes before. And after the environment temperature, you need to evaluate if there's only the upper limbs. We hope there is little hypothermia, the heat of the environment. If we see the room temperature by 24 degrees, but we are doing full body, we need to use at 22 degrees. We need to see the conditions of when you're doing the work. And relative humidity. In Europe, we say this 50% is the ideal, but here it's impossible to find a place with this type of 50% of relative humidity. My recommendation is that you use one and keep the same in every time you get your data, because it's going to have a problem in your analysis. Accommodation time is the time when the person is being evaluated, when they start to be homogeneous to be evaluated. I think that 10 minutes is enough if the person didn't came running, so the body is stressed and needs more time to be cooled down and be balanced. If you have some care, 10 minutes is going to be enough. Other aspect that is important, the camera needs to be perpendicular to the area you are analyzing. So if you see the variations of temperature like this in the image, the effect of angle that the camera is and being studied, we published an article about this, and the distance has a less impact, but the angle there's more impact. So we need to have being always straight too. The Glamorgan protocol is really important protocol we have. They describe in detail 24 positions. You see all of the regions, they are done by the same way. So we need to have at least 10 pixels. You never use the point assessment by 1 pixel because this could be just a noise on the image. But you need to have at least 10 pixels. With bigger the image is better. The amount of pixels. We can use others, yes, we can use it, but we need to take care about the see if there is able to reproduce this evaluation. You see the scale of the temperature scale, so you need to fix the top number. 37 degrees is enough. In the hyperthermy is being used, you see the amplitude of the temperature can be 10 degrees, 15 degrees, or 20 degrees. I can put 70 and the upper body, and the lower body can do 27 or less if you depending on what you're studying. And the thermogram is the false color palette. You see the rainbow scale because it's more intuitive in what is more recommended, but we can sometimes kind like that. The thermogram is gray shade, or sometimes they use the iron palette, but the rainbow is more recommended. The scale of temperature. And just to end, and so sorry because I know I passed my time. The thermal image is a valid and reliable method to assess skin temperature. Skin temperature is influenced by a complex interaction that characterize the heat exchange between the skin internal issues in vascular system and metabolism. The thermal image can be used to study the dynamics of skin temperature, one of many parameters related to exercise and thermoregulation, and therefore has many potential applications. But we need to standardize data collection protocols to ensure the quality of data is appropriate. There's a lot of found of uncertainty, but we need to be sure of the data will be come. Thank you.
I would like to thank Dr. Aderito for the brilliant lecture. And moving on, I will invite Dr. Gilson Costa dos Santos Jr. to talk about metabolomics and precision medicine. Welcome, Dr. Gilson. Thank you. Thank you for your invitation, Dr. Danubio. Good afternoon. I thank you for the invitation. It's so interesting to participate at this Congress with so many different themes, and I'm learning a lot with them. How do I use this? I'm gonna talk about a little bit about metabolomics. I've been working for 5 years in WEG, the State University. I have a lab upstairs, and we offer services. It's metabolomics laboratory, lab-med.com, lab-med.com, and we offer metabolomics services. We offer the metabolomics profile. Since we received the sample, the preservation of it, we analyze the metabolomic profile with nuclear technology. We process the data and create statistics in a portfolio or a personalized metabolic profile if the person wants to address nutrition and other fields. And all types of biofluids that the body produces. And we analyze more blood and urine. This is what we are asked to do more frequently. To start with metabolomics, I always give the context because it's called the central omic information flow. The information flow was called the central dogma of the modern biology. Why like this? Why are you using quotation marks? Because it was considered a dogma, a fundamental concept. But things are always changing, science is evolving. This is the professor who described it the first time. I think you heard about the RNA, the protein. This is his first annotation, his original annotation talking about the central dogma. At that time, DNA replication was already known, the autoregulation, and the message being translated into protein. However, I can say that from the 60s onward, many things changed. These concepts were updated, and we'll still see a lot in some presentations, this linear system. We started with omics, proteomic, metabolomics, there's genomics. They started revolutionize this linear system. Why? Because they started to observe that there are some regulatory mechanisms in the genome, for instance, transposition mechanisms that are not here, but you have epigenetics, I think you might have heard of it, changes that are transmitted to the following generations that do not alter the DNA code. There is this biogenetics heritage. And there is a metabolomics. They discovered some mRNA in transcriptome, and they are responsible for so many functions in the body. Proteins are formed by small molecules, which are the amino acids, and these amino acids are analyzed also through metabolomics. We can map completely the amino acids profiles from various fluids of the body, and we started to believe that these metabolites perform functions, but actually it was not the DNA that was forming it. So these metabolites were actually the ones who were performing functions close to the phenotype. So who forms who here? These small molecules who will form all the rest. This is the Science magazine. It was very famous, where they described that gathering different RNAs, executing different functions, and much more than translate into proteins. Revolutionizing epigenetics, concept that was created by Conrad White in 1946, creating a comparison with this ball that was going down a hill, saying that we would have a predisposition of the destiny of the cell, and it was beyond the DNA. That's why he used this term, epigenetic. And since the 60s or the 70s on, metabolomics started to be very studied. So we have these processes, phosphorylation, and also the DNA tape, where we have 5-methylcytosine. This is called methylation. This is very much studied. What does it have to do with metabolism and metabolomics? Because these changes come from metabolism. Without our metabolism, without products, metabolic products, we don't have changes in epigenetics. We don't have nothing from that moment on. So one of the deviations of this is exosamines, creating the glycosylation, which is a genetic alteration. Methylation coming from methionine, especially our main donor of methyl group is folic acid, because we don't produce folic acid. We need it. If you eat broccoli, cereals, I don't know what did you eat. I think there was something that was close related to a dark leaf. It was folic acid. It's fundamental for the epigenetic profile. So metabolism is central, more central than what you think. Epigenetics, going back to it, brought the idea, Lamarck's idea. We kind of resurrected Lamarck, because his ideas were throughout the years became well known and used. But his fourth law is about the qualities that are inherited and transmitted. And it became some sort of caricature. And it created a model in which we have the metabolomics in a very dynamic flow. This metabolic flow with small molecules that will form other molecules. And we know that nucleic acids, for instance, sugar and on some bases from nitrogen come from acids too. So who is interfering in our metabolism? We know that half of our metabolic profile is associated with diet and microbiota. So our genetic background is interfering even less, but the diet and lifestyle and microbiota is what's interfering in our metabolic profile that will change everything else. Who rotates this road? Lifestyle and bowel microbiota, all of this will interfere, and it's transmitted to the following generations. This is the article that I commented with you, that I mentioned before. It describes that half of the metabolic profile is associated with diet and microbiota in our gut. And this microbiota, the most correct way to approach it is an ohmic approach, coupling metabolomics with other omics. And we start to create a big database with some punctual changes and seeing how the phenotype would change in time. But when it comes to precision medicine, metabolomics is being integrated from this integrative perspective to observe the phenomics. So let's analyze metabolic profile, proteomics. This is called these phenoma centers. We're trying to create one. We have one in Birmingham in the United Kingdom. most recent one was in Australia, the Australian National Phenome Center. The idea is to create this populational data banks, and an article was released. So they create this population bank in terms of blood, urine, genetic background, so, and also references to diet, medication. So you have a huge database, and the United Kingdom has the biggest database. There is another one in Finland that's working with this English database. We have in Australia many spectrums. Here in Wales we have one. Unfortunately, it's very out of date, so we cannot perform metabolomic in it. We are trying to bring another one, an updated one here. So, and each one of these cost around, we're talking about 1 million euros or so. So it's a very expensive toy. And they have mass spectromic, many of them. Each of them are very expensive. So you're talking about another reality, of course, but we have to think in a national way, trying to create a populational database. In this article that I mentioned before, you have this mapping in 2023 from this UK biobank with 119,000 individuals. Imagine what's the power of this biobank for diagnosis, when you want, for instance, to analyze not only one amino acid, but a series of components together and couple them with other data for a predictive power. And this technique, it's fundamental. This technique, this is analytic technique, is very fundamental, it's pivotal for this. We can analyze 209 elements at a time. Out of each, 108 are unique. So we have 1.3 to 3 Tesla, and these ones have 10 to 30 Tesla. So it's a magnetic field with a greater resolution potential. So this article describes a biobank originating from urine, human urine, and it's pretty recent. The human metabolome database is dated 2022, the most recent version. And the 4.0 version had 114,000 metabolites, and the 5.0 has 217 metabolites. Do you think it's too much or too less? What's the percentage regarding the total metabolites existing? So literature says that we only know about 10 to 20% of the components, and the rest is called dark matter. So there is a whole field for investigation. There's this metabolic discovery initiative in America and United States to describe new composites, new compounds. And we can couple other techniques to try to describe more compounds, new compounds. This is a little bit of our work, recent work. We've been working with the Brazilian Air Force, mapping the metabolic profile of some pilots, some fighter pilots, and we've been working together with some physical education professionals, and we are comparing the control group with this in the same Air Force base, with the same diet, with the same training, and the group that starts to fly, the PC-1, and a very experienced group in fighter planes. So they have alterations in several compounds. I cannot dig into it right now. And these are pilots that work that fly F-5 planes. We have the A-29. There is the Gripen plane, which are the most recent fighter planes that we have. It's a company in Sweden produced them. And there is a lot of gravity change inside the plane. Sometimes these pilots present a lot of skin alterations when they finish flying. And we don't know what changes might arise in the long term for these pilots. So they receive a previous training in a human chamber. They showed us the pictures when they come out from this human chamber. They have this red skin all over the body. We have seen the several alterations that we've never seen before. And we know that we know more about astronauts than we know about these fighter pilots. Another work about the effects post-vaccination with CoronaVac and samples that were collected from Agalac here above us. We could compare the same individual 30 and 45 days after the vaccines, whether they had or not COVID, so it's a previous vaccination. The ones who did not have COVID had this color, and red for the ones who had COVID before vaccination. So we analyze the metabolic profile, and there's this delta of adaptation that we call metabolic adaptation for these individuals, and this is fundamental for this immunological response. We have a correlation between compounds in the plasma with levels of antibodies. And this is fundamental to know if they need to have another dose of the vaccine based only on their metabolic profile. So metabolomics has a growing market. We're talking about 8.3 billion. So these are some companies in US, the biggest ones. They offer kits, for metabolomic tests. You can send them samples, and it will give you these metabolomic report complete. Olares has just created a prognosis kit for kidney transplant, analyzing urine of patients that undergoing transplants. We have 3 companies in Brazil. Soon we will have ours here too. Which are the challenges in Brazil? First of all, we should think of our population. We have to have a biobank that we don't have. This is a problem for clinical trials and clinical analysis. So what's the bank that we use for when we are performing urine trials? And the majority of them are done with Canadian individuals or American individuals, so we need a Brazilian profile. Reference values for metabolomics is fundamental. Then we are trying to create one with the InMetro in partnership with InMetro, with ABNT, SBPC, and other entities. And we started with this national initiative, the National Biobank, biobancobrasil.com.br, to create a biobank for our population starting at the UERJ, the State University. That's all. Thank you. This is my email and website.
Dr. Gilson, thank you for the very interesting thematics. And for us to close this roundtable number 5, I'd like to invite the Professor Maria Isabel Castro Souza the dental pre-screening system for profile analysis undergraduate subjects. As Gilson professor goes previous me, it's an afternoon with a lot of diversity, a lot of themes, and a little bit of this biomedical theme as medicine specifically. And I'm starting to, when something works really well, and no one remembers, but when it goes bad, we have a toothache, it takes you out of takes it seriously. And then I'm former student from the house. I graduated here, and I'm a professor here on the house, and I'm coordinator of development unity of the University of Nucleo of undergraduate for telehealth, and it's the only one of this theme on Brazil. And I'm going to tell you a little bit about the pre-triage system for a profile analysis for undergraduate subjects, but it could be converged to other university. Why? Because we are inside of academia where we patients look for us to give assistance, especially for the area of health. But we also graduate professionals to the world. And not always we have a Tinder for the profile of the patient to what we are looking for what our student needs inside the curricular analysis. So for many times we leave these anxious and depressed sometimes, not just the student and the patient, because they came here because we're a reference center and they came here to be attended, and understand they could not be attended because this profile of health of the disease is not adequate for what our students at that time with their ability and competence they are developing. So the work of our students from the undergraduate oriented by me, so you understand the idea of the size of this problem is 3.5 billion people that are affected by for any disease by the mouth, and this is 3.5 billion people. 20 billion people are affected by the diseases, the tooth, by a decayed teeth. It is a worldwide problem. So if you have an idea, the point of view of how the health of the Brazilian is going is the follow-up of this epidemiological profile from Brazil from 2023 and to 2022. Our results are partial because we do not have the final report from ST Brazil. So if you have an idea about the picture is our profile of ages from the pyramid. It's not young people, we age, our country age, so we know the idea of how much teeth are decayed by individual, and up to 5 years to 12 years, and we get on 15 to 19 years we have like the double of decayed teeth on this age range. And then we have up to the elderly, we get to this number explodes. So when we are going to think about the total number of teeth on the cavity on the mouth, you see that is by 65 years to 74 years, you have 23 teeth are going to be lost, have a cavity or being decayed. So in this age range, so the type of mutilation that these populations have at the point of view of public health. And when you have odontology, you think what of her? You think it's decayed. And sometimes you need prostheses. They would lost a lot of time. They need to do implants, and the people doesn't have the conditions. So, health institutions are very well researched by the excellence of the service, and because the service is for free or really cheaper than what it has on the market. So taking into advantage this profile of the information we have in literature by epidemiology data we have on the odontology university, we have a sector about the clinica. We could do descriptions, so you can do a simple analysis where there's a spot for this patient, but sometimes this evaluation review not always equalizes to the ability of the student at that time to solve the problem. So we have on odontology university almost 100 tools, numbers of floors, and we have as an average of more than 2,000 attendments per month, and we have around 20,000 patients with inscription in our hospital. And there's a demand, the patient look for us, and we receive a lot of people who are being called to do because it's an excellent service we provide, and there is a reconfiguration of our curriculum is being based on center our abilities and competence who are gradually linked by the time through the periods of the university. So we did a form of the curriculum of the students when we change what should be centered to the procedure, but to rehabilitate the health, not just physiological but the psychological one to the patient, because we know how much this generates impact in the life of a person. So center on this places they work on disability and competencies. So what is this triage of odontology? They have access to information, including to the profile is adequate to move most of the time from other city to be attended here. And this is worked on a research. I did a work previous from the question we see the change into an app, not just here on the polyclinica, but also to specialists on the university that could educate short enough, with information enough, and with description easy enough so people could to put their own information. So why pre-triage? It avoids the attachment for unnecessary from the patients, and there's legislation in Brazil, we cannot do odontology, the phone consult, so we can do a pre-triage, but I can do it for the first time. And then I have an optimization for the patients and attendment from the patients and students. Again, relation that the patients sometimes get their seat and adequate for my equipment. So then I need to open series of tools, and this has a cost. So this space should be evaluated, and most of the time it doesn't keep here to be attended. So it's generate a cost for the students, to the patients. So we're trying to minimize the situation. So we do what I call you. This has an ethical committee. We pointed these questions to patients and ethics here on the polyclinic. For people, you understand what this meant for when I ask you what teeth you have a pain, you understand what it's a specific treatment. So this goes by validation, and this is a process we call is the first rising of data by creation of software, and this came to the table of the designer so it could produce is a technological resources, development of software, the test of this software as a technical. If the usability is correct, the registration inside the IMPI, it's something we need to talk more about in this university patent. EMPE, and there's a product and we put on a paper, but we didn't register, and someone see it before and then do it before you, and we need to have this culture register things, and then we do not just a test of ability with people, with users, but also with interview semi-structure with our patients and the perception that they have from the patient. Even this person said it has a restoration to do, they in fact have to do, they need to do just that, or they do not see that this gum is red. What's the degree of deficiency of this person from the point of view of his mouth health? You had to see if it's valid to do a pre-triage. So can I click on a video, please? This is the system we had. You're going to fill here the questionnaire. You do not need to download because we understand that a lot of patients do not have the data package, so you can do this. Not everyone has an iPhone, has an Android, and it's from an older generation. So every time we came to work with innovation for health and for health, public health, there's a lot of strategies like digital SUS, program of SUS digital, and then we have strategies from digital SUS. We have other numbers of regulatory marks. Then we can work from the digital and up to the technology being integrated with the public health to benefit the population. We need to think in all of this. Okay, we can work this. I wanted to use the AI. I will do this from, but I need to pay. Maybe you can create something with numbers of tools. They should be free, even if it has some limitations, but it can do effectively. It could be replica in other cities. They could buy this tool. There's technological tool, and you are contributing by this solution by many. So when we are in the academia, we need to think on this senses. These were a test we made. We have the part who are finalizing the test of after we developed the system into the disclosure of it university close to odontology university. We do inside UP with nurses, with IBRAG, and when people need to be attended by dentists, they could do this triage. They came to university so they could do this checklist in the presence of a technical team. So this patient came to the agenda, they were called, they were attended by graduated technical dentists, and then we could see the level or perception of the mouth health and indication, internal or external, of these patients. So what we have are preliminary results inside the software up to now. We had 176 patients registered. It's like 10% of them fulfill it in wrong, so we have a loss of 10 patients. Usually the wrong was the reproduction and the number of the cell phones, so we couldn't follow up the message so they could be attended. So from the 166 we see that 64% of them, when they get the information with the system and what it presents, they were compatible with his own perception. So the patient had the option of two types of treatment. I want a specific treatment, and it could be anyone. You need to do remotion of a cyst in the terminal area. I need to remove the tartarus, so I need to do orthodontics treatment. It was just some specific treatments, or he said I need a complete treatment, and the complete, he chose a lot of things. I have a canal to do in my teeth, I have a teeth on the superior side, and it was less scientific but words, but the users could understand what it is. 94% of these 64 people has compatibility. They understand and choose right that they should have the complete treatment, and just 6% of these 64 were from a specific treatment. And the follow-up we had, what is important, because when we're doing complete treatment, if it's compatible by the level of ability and competence of a student, like the 7th period, and he could go there and solve the problem of this patient and at all. And I have a treatment that is really well specific, I can guide this patient to another level or attending our only canal. So can go to endodontics. There is the only specialization clinic who could solve this, and I solve it more fast, not just a question about the patient but also about the student. So the profile of undergraduate students, they have a description on COI with indication of the graduation clinic according to the profile of the student and the demand of the patient. The treatment, the complete treatment, usually when they are more specific, but there is a lot of rehabilitation, they have a follow-up with postgraduate students, because they sometimes doing research related to this type of situation. But by times you do a technique of implant, you need to do analysis and need a lot of patience, so they will follow up there. And we also had patients with complete treatment, and it was so big the problem that we did an ebook to these patients, and we sent to the WhatsApp, and then the patients from Rio de Janeiro, they came to the specialization students, and not just in the city but the state of Rio, so this patient could find with this address code, can locate where they can go and search for the best specialties. So the patient didn't need to came here. They came from this profile, they received the information and can go home and see. You do not have this profile, but look for other places, because your mouth health it's really important, and this is the external follow-up. How is the ebook that we gave to the patient? This was developed by the students who participate in the project. And here inside the ebook with the geolocalization, there is an active link, and the patient enter there and look to closest public health unity that shows the numbers of localities we have to search for some attending. And the next steps from the research is to send the photography, because it make it easier, but we understand that the photo not sometimes other person not always shows the mouths. You need to send the limitations of technology so we can receive just the figure what we need, so the person understand that how they can give us the photographs. But we also understand with the right tools we can improve this flow of work and offer better conditions, not just by our students but by the information and by the patients. This is my contact. Thank you, everyone. I hope to contribute for you today.
Congratulations, Dr. Maria Isabel, for your excellent lecture. And I would like to invite our lecturers of this round table to sit here in front of us. Guys, we could not respect time. We went a little over, so I will ask you to gently give us only 10 minutes to the questions, because by doing so we can adjust the schedule and we can also assess the posters together with our coffee break. So I would like to start the questions Q&A session with a question to Adérito. Here in Brazil, tomography is starting to be popular, although in a very specific niche in physiotherapy, especially because of its high cost for Brazil of a high precision device. In Europe, it's not so different, but it's not so expensive. My question is, if in Europe, especially in Portugal, the use of tomography is more popular among professionals, or if you have this niche situation for specific services and activities that aggregate value to the final customer, or if it's popular. Thank you for your question. I'd say that less popular than in Brazil. In Brazil, you have more use, that's my perception at least, than in Portugal. it's the same field in Brazil that we have in Portugal, which is physical education, so training. At least I'm following some companies that sell equipments, and they show partnerships with soccer teams and other sports. And in Portugal, we don't have this yet. Wow, incredible. Really incredible. Thank you. Someone else would like to address a question? Good afternoon. I'd like to ask about tomography. You talked about positions. It's something that has been already published. It's your document. I've been researching on it and I'm very curious. I'd like to access it. I don't know if it's available. I think it is on the internet, but I'm not sure. If you could just get my email address and I will surely send it to you. Just send me an email and then I'm going to reply with this information you need. Someone else? Thank you once more to all of you speakers for enriching our Congress. I have a question to the professor. These patients that are screened during this pre-screening, the system, they're exclusively, I see they go to an external network, but it's, partnership with the state. It's through the CISRAC. It's a partnership with some institutes. How does it work? So, truly, the patient doesn't even come here, so it's not regulated because in our odontology faculty, differently from Pique Carneiro, that is part of CISRAC and receives patients from family health system, and at the odontology facility, we're not public health. That's a big issue too, because we have a small fee that is paid by the patient, and sometimes he comes here, spends in transport and doesn't get the visit or half of the service. So what happened when I was an undergraduate student, I need a teeth to finalize my treatment. And I get this patient called, let's say, Francisco. Francisco arrived, and I solved my problem. But what about the individual's problem? So this is a totally corrupted logic. And the patient, of course, does not come because he is simply assessed. And depending on the format that is given to him, the tomography will help us. If you come from Macaé, do not come. It's better if you look for something in Macaé or close to it. These XYZ services, because we want to improve feedback to the customer and not only solve our issue regarding the academic and the undergraduate course. Of course, I have to prepare the student and I have to give proper training, developing all the competencies within the framework. But what we do, since the State University is in the city of Rio de Janeiro, in this first phase, the idea was to enable the residents of the city where they can seek for free treatment. Professor, since I've been working there in Odonto, I'd like to pose a question. At that time, there was no expense on the part of the patient for any treatment at the State University of Odontology. Why do we have it today? So I don't know how long ago you're talking about. more than 32 years. So when I started in 1989. And at that time, the patient already paid a small minimum fee. But there were many projects and the patients were included and didn't pay anything. So in research projects, when the patient is referred to a clinic, to a facility, for that profile, he or she does not pay. But in a specialization course, and the patient wants to change and some procedures, he will pay. He or she will pay. He will pay with it's something very very minimum. It's not really comparable to what he would pay in a particular for a particular private treatment. But I know that even the minimum fee is so much for someone who doesn't have anything. But even isn't the universe, the state universe, funded by the state of the state of Rio? Is it fair to charge? But now, if the odontology department does not charge anything, you're gonna close because it's very expensive. It's a very expensive investment. The odontology student spends a lot of money. The problem nowadays, and in general terms, especially in health department, the problem it's not is it to maintain the student in our campus setting. Is it fair? Is it correct? There are other ways, of course, and in the world that we would like to, where we would like to live, it would be very different. But it's better to keep to guarantee to safeguard the minimum that rather than not having not even the minimum. By finishing this roundtable, I would like to thank you immensely for collaborating with Mevitih. Congratulate you for your contribution. And now I would like to handle you your certificates.
Por nada. Parabéns.
Boa tarde.
Good afternoon. Let's move on with our schedule. We're going to roundtable 6 about technological innovations in health monitoring. And I would like to invite Dr. Annelise Sonzer, who is going to talk about peripheral and cerebral muscle oxygenation, clinical applicability and research with near-infrared spectroscopy. It's an honor to be here in this event with my colleagues who are really prominent figures in their fields. So I thank Professor Danubia and Professor Mario for the invitation. I am the Professor Dr. Annelise Sonza. I'm associated to the Department of Physiotherapy at the University of Santa Catarina and a full professor of the 2 programs of this institution in physiotherapy and in sciences of the human movement. Today, my presentation is more of an informative one about a technology that is being widely used in health, which is the near-infrared spectroscopy to use in peripheral and cerebral muscle oxygenation. So what's this technology about? It's a non-invasive optical imaging technique used to assess tissue oxygenation and hemodynamics. So we are able to measure oxyhemoglobin, total hemoglobin, deoxyhemoglobin, saturation index in real time through a continuous measurement within the near-red infrared and near-infrared. This is used in many fields. It analyzes organic and inorganic samples through electromagnetic radiation with what we call vibrational molecular spectroscopy. So we can measure biological tissues such as brain, muscle. We can measure quality of grains. This technique can be used in agriculture to control the quality of animals' diet. And in general, in agriculture, it's well implemented. The focus is to speak about bio-oxygenation and biological tissues. So we first start to talk when this technique appeared in the 19th century. Wilhelm Herschel in Germany. He elaborated the physical principles of this technique, and only in 1916, Carl Norris in the USA implemented spectroscopy to be used in agriculture. In 1972 and 1977, it was started to be used in medical application and through pulse oximetry, which is widely used. And it's a device, a very cheap device, widely used in medicine. In 1977, Jobs wrote the first publication about this technique to analyze biological tissues. So publications about this technique would assess in a very deep way tissues. That's something very different regarding pulse oxygenation, because this will arrive in the muscle and the brain to measure tissue. In 1985, the first clinical studies in neonates, especially measuring functional nerves. In 1989, we had the first commercial nerves, in Japan, and 92 the first news for measuring brain in US. In this image, we can see a neonate using a channel. This device with a transmitter and a receptor through which the infrared light will pass, and the detector will register the measurements of the biological tissues. In 1994, we had the first portable NIRS for muscle measurement, peripheral muscle measurement in Japan, which brought a real advance in this area. I had the possibility to go to the field and make research with the portable equipment. It facilitated immensely the use of this technique. Nowadays, this equipment have multiple channels, even more channels, which brings richness and precision to the measurements. Softwares and signal analysis are improved. We had improvement of signal capture, especially in an external environment, because light is a limiting factor for this technique. So we have more efficient equipment for the measurements. That's saying that this technique with near infrared is an alternative to the functional MRI. I'm not saying it's going to replace it, but because they are two different devices, but it's an alternative with a very lower cost with respect to the traditional MRI. Just for us to have an idea, I have performed a research in PubMed, the first article of Jobs in 1967. Please, in 77, see how we had a growth in number of publications, and now we have more than 30,000 articles quoting or mentioning this technique. We have an exponential growth. And what would be the principles, the NIRS principles? One of them says that it uses the near-infrared region of the electromagnetic spectrum with between 700 and 2500 nanometers. This is the region that we call the near infrared. And now we can see the spectrum, the electromagnetic waves, the visible spectrum, and the near infrared from the visible light from 700 to 2500 nanometers, and the equipment will perform measures in this area. And how is it possible? How can we differentiate oxy and deoxyhemoglobin in measurements? It is based on the principle of light absorption by chromophores in biological tissues. So what's the big deal here when we talk about this technique? We have oxyhemoglobin with chromophores, which will be in a spectrum which is with a wavelength that is different from the oxyhemoglobin. This allows for a transmission of these photons through organs in situ for the monitoring of cellular events. And here we can see in this image the stratum corneum. We would have here a measurement of our pulse oximetry, and the great advantage of this technique is that we can deepen in this tissue through its properties, in which oxy and deoxyhemoglobin, they have an absorption of chromophores in different regions of the electromagnetic spectrum. So if we see the graphic in the y-axis, we have this molar coefficient, and in the other axis we have the wavelength. If we get the area corresponding to the near infrared hemoglobin, we can have a better absorption, around 750 nanometers. And when we talk about dioxyhemoglobin, we have 850 nanometers. So this equipment can differentiate between these two elements and measure what's happening with the tissue. This is a non-invasive technique using modified Lambert-Beer law. This law is based in calculations, and we need to know how much light we're getting and how much light is coming out. The optical path, the distance that is done by the light, but Lambert-Beer law is not enough for us to have a precision with this equipment, because when the light comes in, many things can happen in the tissue. One part of the light is going to change direction, be reflected. Part of the light is going to be absorbed, and another part will be really transmitted to the receptor. So not all the light that comes in will be used for the measurement. So we need to modify Lambert-Beer law in order for us to have a compensation for the change in direction of light in the tissue. And by doing so, all this process that spreads and absorbs light that is caused by these near-infrared waves, it will bring to us measures, relative measures. They are not absolute. And now we can see the probe that we call uptotal. They will pass through our biological tissue, creating what we call a banana shape, and create the measure in a very deep part of the tissue between 1.5 centimeters and 2 centimeters. Here we have the source and the detector that will measure all variables: oxyhemoglobin, deoxyhemoglobin, hemoglobin, the total hemoglobin, which is the total amount of blood, and the tissue index. And that's different of what we have on our pulse oximetry. In our muscle, we're gonna have a range that varies from 80 to 60%. So this is the normal range for oxygenation measures. Here I brought a graphic to you. In blue we have deoxyhemoglobin, and in red oxyhemoglobin. In pink the total hemoglobin. And here we have a lactato curve showing that we have an incremental exercise. First the individual is in rest, then it started the exercise, and the intensity was being improved. I was consuming more oxygen, and in this moment is the moment I stopped my activities. And then I have an improvement in the flow, and consequently the inversion of the graphic with oxyhemoglobin increasing and deoxygen decreasing. So what's the applicability of NIRS? It's very broad, but thinking about what interests us in terms of health applications, we have several studies about FNIRS, which is the functional NIRS, and a great amount of studies that show that this equipment can be used in cardiac surgeries. And we can use for cerebral monitoring during surgeries, and we can also use it for monitoring the own cardiac muscle in situ. Here we have studies that offer algorithms for cerebral oxygenation, including studies that bring the information that some levels of oxygenation can predict mortality after cardiac surgery. So they have a very interesting applicability. Here, in situation operative for neonates to monitor the spinal perfusion and with so on with some conditions and chronic disease. Brain oxygenation is very it's all well used, implemented in cognitive function about fatigue, sleep deprivation. So there are many studies performing this brain oxygenation measurement. We have some studies, for instance, this one, cognitive studies in patients with multiple sclerosis, and so on and so forth. These studies are growing in number as the technique becomes more and more popular. Neonatology, we have a broad application here for brain oxygenation, and through procedures before and after surgeries, and if you have to perform an intervention, for instance, in this study, we assess the brain oxygenation in preterm children treated by caffeine and so on. So we have a large amount of studies in this field. When we talk about the use of muscle oxygenation, also here we have a wide applicability from the elite athlete in when you're measuring performance to other conditions, other situations of non-high performance athletes, to measure hemodynamics and the tibial muscle in rest during and after, and some exercises, concentric exercises. In terms of rehabilitation, we have a lot of studies, for instance, the effect of neurofeedback facilitation on post-stroke gait and balance recovery, patients with multiple sclerosis. We have a series of studies that are related to rehabilitation. What concerns the studies that we have developed in our lab, we have a research group about the functional aspects, orthopedics, and the development of children and teenagers. We have a series of publications in the last years, especially in musculoskeletal field. We have several studies with some specific interventions, and we perceive the gains or not of this oxygenation, measuring pre and post intervention with dry needling, peeing, and muscle oxygenation in children. Pre and post myofascial organization, pre and post clinical trials. You have a series of studies that have been published in the last years using this technology. The studies that we have that are ongoing right now in our lab are related to the brain oxygenation, which is another challenge that we have. When we talk about it, we have so many channels, and the equipment has its own limitations that make it difficult for us to capture the signal for the brain oxygenation. And regarding this study here, which was performed by a student of mine, we assessed children with heart conditions, congenital heart conditions, during functional tests, 6-minute march, and we assessed 6-minute step, and we assessed these children in real time. What can we say about the limitations of this technique? Probe, the optodos, they need to be in contact with the skin without light. So external light cannot interfere because it will interfere in the signal. Presence of hair, so it's hard, you know. We have to put we have to use a cap because we cannot ask the person to shave his or her hair, of course. So maybe you can in army, but so we have to separate the hair, displace the hair. So you know, change one side and have to change the other side of the hair, so it's complicated. We have a restriction in terms of penetration from 1.5 to 2.5 centimeters. When I'm talking about deeper tissues, I cannot reach them. We have this limitation. There is no standardization for data analysis, and in general, artifacts are not corrected by software. So these are the main limitations for this technology. As final considerations, we have a tool that is safe and will not emit radiation, acts within physical principles, and has been used widely with great importance, and it's been growing in usage. It has a non-invasive nature and provides us real-time data, and of course, and it allows us to use it in different fields and situations. We always need to consider that this technology has limitations, and we have to respect it so that we can have the better quality in the signs we collected. And as technology advances for this technology, companies are always refining softwares for health purposes and to understand physiological processes. This is my research team, and I am very proud of all of them. Our fellows and our extension fellows, our scientific fellows, they all work in several other projects of our lab. My master students and my PhD students, which are my left and right arms, so that everything can proceed well in my lab. Thank you very much. I am available for questions.
The orator and very nice presentation. So we have to go on with the second presentation. It is Professor Fernando Silva Guimarães about functional assessment of hospitalized patients. Thank you.
Good afternoon. I'd like to thank Professor Danubia and Bernardo for being here again with you in this house. So I like to talk about this theme. He's very large. I would like to start with evaluate the functional assessment of isolated patients with focus specific on how to select the tools to this population. I'm a professor from UFRJ. I'm from physiotherapy. And there is no conflict of interest. According to the Confederation of Physiotherapy, we do a reevaluation, part of the therapeutic process, and we direct this follow-up to the patients through different phases of his follow-up. The model that is more indicated, recommended, so a number of patients, not just hospitalized, but a general way, especially on the International Classification Function Model of Function on the World Health Organization that consists in 3 domains: structuring functions of the body, activity, and the participation and the environmental topics, and also the personal context. So this is biopsychosocial model is being recognized on this area of recognition, so of rehabilitation. So from this model, it's possible and is recommended to have the selection and the choice of the tools of evaluation, trying to find out the domains of structure and function, activity and participation. When we talk about body functions and structure, it refers to anatomy aspects, morphologics, and we have the muscle function here. We can subdivide by endurance from aerobic endurance or anaerobic endurance, the flexibility, the strength from the muscles. That is part of the muscle function in body function and structures, domains of the body. And some examples of evaluation, we have a number of evaluations of functional therapy, intensive therapy. We have 60 tools of evaluation, so we're going to have a generic approach here. We have the perimetry of the calf as some limitations to ultrasound from the muscles. They're being used as a resource, technological resource that provides us a better measurement. And in terms of muscular function, we can do a manual test that's very well known, but it's a subjective evaluation, and there's a protocol we should do. But it consists the strengthening muscular determinates being that the individual should realize to do the movement. And there's a technological research for the same ending. I can have this portable device, and there's a lot of dynamometers. They are very useful on the hospitals, like places we can't use big devices, or when the patient is hospitalized, so we can do a more objective. So here on the left you see the structure, and on the left you see the evaluation of the function of the muscle. Is go to the simple and to the more advanced one, and have the domain of activity. The means you're talking about the action of the individual to how we can do certain activity of self-care, as the sit and stand up, any activity related to the basic living caring. It's the domain of the activity. And aside the domain of activity, we also have the domain of mobility that involves transferring, climbing, coordination, balancing, walking. Is just some of the examples of mobility, or the compounds that are involved with mobility. Outside this domain, they have a lot of tasks we can do, like the individuals, they sit, then stand up, and go through a place of 10 meters, and there's a times we've been seeing the clock and the time you take to realize the resource is being computed. It can be the time of falling and to realize this task so you can do it. And the other tasks are simple. You can sit and stand up with some variations. You can do this for 5 times. Bring chronometer. With worse the times, the worse the individual. So you're going to, or maybe we can sit and stand up numbers of time, and you're going to count how many times they got did it. It's a task of exercise, like effort. If we see a way that is simple, practical, without needing a more sophisticated device to do it. And the mobility in terms of transferring, like supine the cubit from the bed and stand up to the chair, and these variations. This type of things we do with a specific tools for this ending. So it's very useful. So the hospitalized patient, especially to the ones who are being on the hospital for a long time. And there's movement sensors. We talk about this type of sensor here on this event today. We can see from the accelerometers. They're simpler or who are more complex, like with the unity inertial unit of measurement. And the sensors, they are put on the arms and the head and the chest, and you can see the movement of this individual doing some type of activity in function of time, and the modification that they do as an angle of the movement. For example, I have the hips, I have here inclination of a pelvis, flexion of the hips, and flexion of the knees. So you can compare this study from the activity to sit and to stand up with individuals who had COVID and individuals who not had it. So we see the difference with the curve on green and the one on blue. And blue is the one who did not have the COVID. It's a different pattern between these two groups of individuals. And there is a video. You can be without the sound if you want it. As I said before, there's no conflict of interest, but I would like to show you this type of sensor of movement. This inertial movement you see here with just a bag, and the patient could be hospitalized and use it, and this device, you can use the electrostimulation, and the individual can use numbers of tasks, and sometimes they bring some protocols for the tasks, and then you can have a better analysis of this movement, of the biomechanical. It's better used with ergonomics. And there's a software who is dedicated that allows you to analyze offline and to emit a report from the patterns of the movements. So I know some studies that use this system on hospitalized patients. There's a lot of potential that you should explore, and there's also some activity inside the self-care activity like hygiene, dressing, eating, toilet use, and with a number of devices you can use together, specifically developed for this utility, like cats that were developed for elderly people, but now we use for every type of patients. For like Borthel index, we have some types of cats index, like go upstairs, and the Groner index is another scale we use a lot, but it's more abroad than we can use to the mental functions, and it's a success. And what about their participation? It's not just about the hospital, because it's the participation of the live activities that involve the participative life of this patient. So we have some activity study, and the fun, and then you have when the patient is hospitalized, it's difficult to see this, but we may follow up after they've been off the hospital, and how to choose the factors considered when selecting an outcome measure. What I'm considering when to choose the scale. First, the purpose of the assessment, the two measurements, the clinical utility, involving like cost, training to the team, the equipment required, and of course the patient capacity, the profile of patient from the point of view of the doctors, the clinical view. So who wants to know more about this subject is interested to access the website from Cosmin. So we have this objective to help professionals to find better tools to outcome measurements. We have now a diagram of Cosmi. It's the measurement incorporates the reliability, responsibility, and now we're going to give you some examples of physical function outcome measurement for hospitalized patients. The have here timeline since from pre-admission to discharge from hospital. And I'm going to describe it. And how is going to evaluate him if it doesn't have a time machine? Well, we're going to talk about the recording, talk about the family or the own patient. It could cooperate. So I have an idea of the functional state of this patient before being hospitalized. So I could have a more realistic perspective about what point I can get with this patient in terms of functional, and there's a scale of mobility, clinic, BMI, Barthel Index, and you can use and document this data respect to the functionality pre-hospitalization. So my patient is now hospitalized, didn't wake up, he's unconscious, it's really normal from the first days. So how are you going to make the evaluation for this patient? The functional ones, well, we can evaluate the muscular functions, the muscle strength is difficult, so you will resume from the first domain only. From SIF is the functions of the body, like do the ultrasound of the muscles and the bioimpedance from the body. You can do also in intra-hospitalized. Awakening patients in ICU, your clinical stability, he is awake without being agitated, without delirium, and with good cognition, understanding what you are saying to him. So I can do some of this evaluation with him, use some mobility scales. In the last 15 years, we had a number of scales to evaluate patients in the ICU. Or we do manual pressure. It's not our objective to see the strength of the hand. It's had an idea about this peripheral strengthening of the muscular, because you have a good relation with this, with the global muscular strengthening. So related to the scale, you see a lot of tools with different objectives. During this, you can see the strength ability, respiratory mobility. There's a number of scales you can use it, but some of them go beyond of the mobility. FSS, ICU translation cross-cultural adaptation. You can use it and be from the Brazilian Portuguese, not have a free translation. There's a process from methodology to do this procedure. So look for published, translated translations from the Brazilian, and have mobility. You go from rolling to supine to sit, on sporter sitting to sit to stand. For each one of these tasks, I have a score that came from 1 to 7. There's a patient who is more independent. Another scale of mobility is the ICU mobility scale. It's more hierarchical. It's going to 0 to 10. Then 0 is a patient who is capable of doing any active movement. And 1, the patient is sitting on the border of the bed. And in fact, when we look of the UFSS, I have 7 levels between the patient on the supine and past to the L. So I look here and I have a sensibility. We have these properties from the measurement of scale. We have a sensibility way bigger comparing to what is 2 tools of measurement. You have UFSS, you are here on the right, and UCU is the left one, and go to 1, and there's no the middle levels, and we can see here different alterations mobility when I use the ICU mobility scale. So I'm going to use just UFS as well. Depends on the profile of your service. Doesn't mean the ICU doesn't serve for you. It can take the mention to what is this need you have. Maybe you need more time to recovery. So all this must take accounted. And the manual muscle testing, movement tested on each side. You have the score for each movement from 0 of no movement up to 9 that is the normal muscle strength. It's an interesting test, practical and validated, but there is no good way we reproduce it to evaluate muscles in movements that are isolated, like individual muscle groups. You see the 0.15 to 0.75, and we know the ideal is 1, so let's go a little bit faster than my time is saying that. But we have a total score that's nice. So I won't use this type of evaluation. Well, you can use it, but if we're going to compare muscle strength of determined movements, the specific ones, especially if we do with different evaluators, it's not going to be a good option. And we have the outcome measurement construct is the CPACs. They see respiratory and mobility function, and the skin one, you see the mental state of a patient, for example, and have prefix. You have 2 items of mobility and 2 items of muscular strength. We need to look inside and see what's best for you, because the type of the scale, we generate a score that is what is important to generate the score. So if it's important for you, so you need to choose it what is best. So if I'm concerned with the barriers and the mobility, I need to look to the specific item who is inside the scale. It's not just use the scale. You need to know what you're going to be evaluating inside the scale. So my patient is on the infirmary. I continue using the ICU mobility scale because it is from ICU, but some hospital use it on the infirmary. So, generally, some patients has a better mobility, but a functional one. And these were developed for patients who are more serious. So you see 50 patients from University Hospital from UFRJ, and they use UCU mobility scale, and 7% of these patients have a score of 10, who is the top level. So we couldn't describe the mobility of this patient. We call this ceiling effect. We should take advantage of the instrument who is appropriate to be measurement. The difference between the individuals, there should be not just a floor and not either a ceiling. So we need to use the evaluation who was much more used on numbers of patients. You're going to see this result. A lot of patients who have the minimum score, you see the floor effect, or if you have a lot of the 10 scores, so you have a ceiling effect. So we need to change another scale. I'm ending now, so there's another test who can be used on the infirmary. So going to another extreme. the previous test I showed you, the mobility scale was too easy to the patients. Everyone was taking 10, and now I have the sit to stand test, and were applied to UCI survivors, and only 30% of ICU survivors were eligible to perform the test. So it was really small sample. So you need to evaluate the profile of the patients of your hospital. So to take account of this, see the statistics and what is best for your patient. If it's adequate to the profile of patients of your hospital. So the scale of there's a good accuracy, seeing the readmission of the patients, and we have a number of management didn't see the aspect. So the patients have discharge with a lot of problems, and we call their predictive validity. Just so to end, now I have the ICF framework. Is recommended to framework to structure a comprehensive set of outcome measurements for assessing physical function in hospitalized patients. Their assessment, it should see the individual and individualized characteristics, taking account considering the clinical settings. Cultural adaptation, use instruments that were translated and culturally adapted to the target language and population. In Brazil, should be Brazilian Portuguese, not Portuguese. So, measurement properties, prioritize outcomes measurement with stability, reliability, validity, consistency, and responsibility. Technological tools, consider technological device like musculoskeletal ultrasound and other tools that should have a better objective evaluation. And for the post-discharge assessment, you should consider using instruments like the HUDAs from the WHO to assess functionality and the domain participation and hospital discharge. And thank you, everyone.
Thank you very much. With very good concern with evaluation in hospitalized patients. I have to call my friend in the floor. He speak about smart fabric for monitoring the body's physical and medical conditions.
Thank you very much. Before the start, I would like to tell to my friend Mario and Danubia, thanks very much for the invitation, and it will be the pleasure to share with you. I know it's the last presentation of the day. I know that you are very tired. I will do something a little bit original. I will be faster in English, and after I will make a little resume in Portuguese. And I am very happy. I start to have one teacher today, Alessandro. Thank you very much. Yes, thank you. Okay. Which one?
Yeah, forward, back, and laser point.
I will be just forward.
Yes.
Forward. Okay. For my presentation, I will talk about the smart fabric, the smart textile. I am working in this field since more than 30 years. And I will share with you what I have done with the high-level athlete. Also, I work for Brazilian, Cesar Cielo, in swimming, for the swim fabric. And what is important for me, not it's the gold medal, but the application in the medical field. And I would like to share this information because the fabric is the future for human, and we can think about it together. I will show the objective on first, after some information about the method, the results, and we will discuss. I will discuss the different results. I have some publication in this field, but like you know, it's the work with the industrial. That means the industrial give a lot of money, but it's forbidden to publish. They are not interested in this field. That is why all the results what I will present is with high-level athlete concern with medical field, but they allowed the publication, but 10 years after. Okay, the latest technology, it's forbidden. In the contract we sign that the results cannot be published until 10 years, 15 years, when we arrive to other things. I was young when I started this work, you know, like you can see, it's 30 years before, you know. And all this, what you can see here for different sport, the latest for American was with the fabric finis. What I can please just to the pointer.
The later,
Yeah.
The red button.
You know, I am very bad in technology. The last one, I was working with the arena for 13 years, and since 3 years, I start to work with this American company, and all this, what you can see here for cycling, for swimming, for the World Championships in cycling, this all was my think about. And with the industrial, I give the think about it. They have the machine, and they develop all these parameters. What I would like to share is just around this kind of fabric. I will show you that these fabric are very clever and can give a lot of help for the muscle work, and to share with you all this technology. But here I worked for the skin team in France. The objective was, like you can see, I published this work in the Journal of Biomechanics about the fluid mechanics part. It's the interaction between the flow and the human body. The aim here is to increase the lift for the high-level athlete in the aim to go very long and to win the medal. This work was with this. This is the best swimmer in French called Laure Manadou, and this the same team here, what I follow for 10 years, something like that. And also I have some application in the industry and also in the sport. The concern for the present study includes swimming, triathlon, textile, for sport, for hemiplegic. Hemiplegic, it's my actual work. 13 years for high-level sport, and the application for what is the objective for hemiplegic is to put it here on the water, and because they can't, like you know, to go on the water for the flotation, you can move the incidence of the hand on the water. They have usually the hand like this, they can't float, and the objective is just with the textile to give them the possibility to have the big force and to stay on the surface. As I don't know, François, can you tell me please, bouchon, how we can tell in English? Is for the bottle, you know. I don't know in English. As bouchon on the surface, you know. What is the orientation? The story of my work, you know, for starting, not this one is old than me, but I started this work with Matt Biondi. It was the reference in swimming in this period. And all the athletes, what I follow is with all this kind of fabric, what we developed to help them to increase and to win the medal. What is the orientation that we can? Inside, the industry will give a lot of money, but we have a lot of research. I will start to talk about swimming. It's the same like Formula One. The swimsuit is the Formula One in swimming, you know, and you have a lot of technology, a lot of research. And what I would like to share with you, that means you have the research development, the different question, and I will share just by different image that we can see inside just one fabric that you can see the high technology for the woven fabric, breaking innovation with multidisciplinary approach, the fluid mechanics part, the interaction between the fluid and the human, the modelization and simulation of the body, and after to compare the analysis of different fabric that we can develop, and at the end we put this fabric inside the water tunnel in the aim to quantify all the fluid mechanic part. That means we have a lot of mathematics inside this kind of tool. The story of the textile and the fabric, just to show the different orientation that we have got since 1,900 years until the latest. I don't know if I have the Brazilian here. No. And to see what is the main orientation is to say that between the yarn, during the fabric, you have the possibility today to tell just for one fiber to follow the muscle, or to compress the muscle, or to make the force in one area or the other area. That means today we have the 3D fabric, and we have 3 yarn. For the first yarn, we can give him the information. The second one, the third one, according to the movement, and according, for example, for the development of what we have today is to make the hemiplegic and on the water in the aim to make this possible rehabilitation. This evolution until what we can see here, we have a lot of technology, but also we have a lot of simulation. That means when we talk about, you can hear me? It's okay? When you talk about fabric, that means for this kind of fabric called arena, they are the first in that way, and that means we have a lot of technology. We have to simulate the flow, the modelization. For example, here is the interaction between the flow and the human body. And after we have the development of the fabric, and we go until to simulate the fabric that we have here. That means which orientation we have to put on the first yarn, the second yarn, how we can, for example, make the connection between the yarn until the latest development where we can glue one part to another, you know, to decrease this resistance. All these parameters, we make them by simulation. That means the experimentation for boat, for swimming, for the plane, and all this stuff, we have just to make a little model because it's very, very expensive. That means the modelization and simulation are the most important part to decrease the number of experimentation. For the first, the most important thing for me was to decrease the drag, the resistance, according to the flow here, just for the sewing part. Try to see just the drag, the difference between the drag when we have the sewing part and when we decrease this part, for example, by gluing to fiber. And the difference is very, very high. Also, after we have the possibility to make because when we simulate something, even if I show you just a little bit before this picture, it's good to see different color, but if you don't validate the model that we develop, it's as a joke. That means all people can simulate, but the most important thing is to validate the model that we develop. And here, after, for example, for this model, we go in two areas. This is the flume, all the model of boat that we can see in the world. They make this kind of experimentation in this water channel. And after, we put the swimmer in the flume and also to calculate different parameters in the aim to validate the model that give us a help for the different simulation. Okay, all this parameter, I am talking about the last work. It was for 2 years before, just for this kind of development. And now, what is the? I would like to ask a question now. How I can use all this technology for the patient today? Because we have a lot of technology about, and people not know what we have inside. And I think that I am sure that it will be as a water for the rehabilitation is something for the future, and you have to bring and to exchange together. What is for this I gave just the little title, from the hard ground, the contact that we have, to the water. And I would like to talk just about the orientation that we have with the muscle, you know. That means all people know here the physiology. It's not the aim of this slide, but just to tell that today the yarn that we develop can make all the orientation that we can see here with the muscle contribution. That means with this clever part with the yarn, he must follow the orientation of the muscle and go with the muscle and not contrary to the muscle. This muscle can give us just with the ground when we make a lot of repetition. That means it occurs that we will have the fatigue faster. And if you take just this muscle and around the sarcomere that all people know, for this muscle, he can give us two possibilities to make the force. The first one that you know, the relation between force and length, and the second one, the force and velocity. For the orientation that we gave for the yarn is to tell which, that we know that here we have in the high velocity we have a little level of force, and for the high level of force we have a little level of velocity. That means it was our first thought to tell what is the information what I have to give to the yarn to give me, according to the objective what I would like to develop, to be in this area or to be in this area or to be in the high level of force, even if we have lowest velocity, etc., etc. And the second thing is Anke this morning, I am sorry she is not here, but I will follow the discussion with her. She told about the compression, and it's something very, very hard. And we didn't find the time to discuss about the point, but to make the real pressure on the muscle. As you know, the pressure is the rapport between force and surface, but which area we have to put this pressure is something very, very hard. But I will follow the discussion with her. With this from the hard ground, we have a lot of possibility to carry in the hospital where I work with François. Now we have all we have some. The force plate, we will have the 3D in few time. We have the force plate, and we have also the possibility to modelize this parameter. But the most important part is to talk about the the implication of the fabric on the human. Here we have one hemiplegic patient that we can modelize. I don't know. Sorry. Yes. That we can modelize and to make some simulation. The objective is to see the progress of the patient and after to give to the physiotherapist the different information, how we can improve the quality of life of patient or to improve one part or second part. I am in the same time from the hard ground. Like you see here, we take just to level the loading for the quadriceps, for example, and for the plantar flexure that we can see here. And now all these parameters give us the orientation to think about people who are using the wheelchair, you know, because a lot of colleagues here talk about ulcer and all these parameters, and the aim how we can put them on the water. And if I resume all the interaction between the ground and this hard ground, we can calculate a lot of things by using mathematics. For instance, the inverse dynamics can give you the possibility, because when you use the force plate, we will have just the mean information about all the body, but the question will be what happened on the ankle, what happened on the knee, what happened on the hip, and you can go until the head, and this, by using mathematics, it's something very possible. Also by the ground, in the hospital that we have, where we work, here we have the robot. This robot, I am not doing anything. You give him just the information, the kinematic of the movement, and he's moving. But the objective is to the user of the wheelchair can make this possibility to stand, you know. And here we have just the physiotherapist behind. He follow, but I am not doing anything. Just to give the robot some information, the kinematics, and he will do by use, for example, increasing velocity, decrease velocity, but not for the position, because we have the physiotherapist behind to give help of the patient, and during the first period. Now, for the water, what is the most important thing is to use some principle that will give help to the patient to go on the water. Thanks to Archimedes, all people know this, and some calculation, the idea is with the yarn, what we develop with the industry, to give them the information, to give the big high force to push the patient on the surface, and to give him the possibility of first, because no people, this project, no people developed this project until this now. We don't have this possibility. I am working with Dupont-Nemours, the first, the reference on the fabric in US, and we are working on this project. And if I arrive to finish this project, I will be very, very happy, better than the middle, what I saw with the high-level athlete. Some calculation, some mathematics as usual, and the objective is to around to this position, okay, by using different possibility for this patient that we can put on the water. What is the possibility is to make a lot of research on the interaction. Here we have just the interaction between different yarn, and that we can give that we can give them the information to go on the reorientation of the muscle or to put pressure, etc., etc. I will show you, for example, here for the objective for the swimmer. I said I have to have one drop who not like the suit, because when the drop arrive, she must go faster, because all this water will be carried by the athlete, and we are working only for the 3 medal. That means if the athlete can have this water with him, he will decrease the performance. I use this, for example, for this objective. And, sorry, qu'est-ce que j'ai fait là? Or the machine, for example, the microscope that we can see this, how we can decrease the resistance. Just here we have just the drop for the water, and I have to make some calculation that can not interact with during the movement by using all this kind of tools, and try to see if this one is the latest development that for the what we need in to ameliorate the flotation. This the connection that we have here is the fiber that he can go with all the direction of the muscle, as the picture I show you in the introduction. That means he follow all the orientation, because all this orientation can give us the possibility to have a lot of possibility of movement. And this just I share with you sorry. I share with you just you know, for example, all this parameter that we have here, because here it's the big objective. All this what we add here for this parameter can give you the possibility, for example, to stretch or to move or to go by using pressure or by using pressure or compression, etc., etc. As I told in the introduction, is the industrial part, and we are in the latest development for this suit that will be cover all the body, working for the ulcer on first, and the second to give the help of to the patient to go on the water. Try to see here, for example, for the first time since 3 months, we put the carbon fiber here in black, and the carbon fiber will take the homogeneity for the behavior of the fabric for each zone. That means this carbon fiber will give us the possibility just for the little surface to have one homogeneity, because after the first utilization, the second utilization, we will not have the same behavior as the question what I was I would like to ask to NK is when the patient use different compression, the compression is not something linear, and she cut faster, and for this we have to learn about this. It's what I would like to share with you, and they show me that it's the end. And thank you. And for the resume in Portuguese, I would like to tell you just tudo bom. And I am happy I have a teacher the next year. I promise to take 5 minutes in Portuguese, and I have also Aderito. He will not forget me. And it's a pressure, but my objective the next year is Portuguese. Don't forget me, Annelise. Thank you very much.
Thank you very much. It's very exciting to apply this smart fabric in our patients, and Reda so show you our new hospital in France, new hospital of University of France center, hospital center, and my office was just up. Thank you. We have 5 minutes because we are late, and I take the microphone to you after. So, do you have questions? Yeah.
Para Annelise.
To Annelise, I would like to comment and ask you if you know, because there are some people in São Carlos that are studying a lot substances that are optical clearers that will allow us deeper understanding and deeper analysis of this. And these bleaching, this whitening, they allows for more light to come in, you know. For photobiomodulation, people use it to improve the deepening of the penetration. Thank you.
The reality, the big problem we have is the microphone has no sound. We're not receiving the sound. There's other limiters from the technology. When we have a patient that have a very obesity and or tilting also didn't collect because if you tip on the light, it can't, for example, on the fat tissue, so it gets to the bones, not going to collect. So if we would be interested if we test to see it would help in the improvement of the sign collection. Oh, that's nice. The person is not speaking to the microphone. You have the yellow. I don't know the name of the yellow that could allow to visualize with the abdomen of the rat, and we have the optical clear from the of a way you could see through the internal organs of the animal. It was done on animals, but it was optical whitening is the twilight yellow. He's not speaking to the microphone. Thank you.
Patricia here. During your lecture, you spoke about the clothing, right? You spoke about the clothes. So her question is about if it is possible to build in cloth considering the tension of the myophysical chain.
Yes, it's my opinion, and she talked about gloves, huh? Gloves, yeah. We work in, sorry. Sorry. Yeah. What I will tell you, the response is very fast. If you take just the suit for the athlete, what I showed you. All the fabric, you take Adidas, Nike, all we have in the world. Just the fabric for the swimsuit, for the technology, and also it's equal, just for one athlete, Cesar Cielo, Brazilian, it's equal around 4,000 euro. Just for one race. That means the strategy for them is to wear the high-level athlete, to win the medal, but after you and me, you take another thing. You know, it's impossible to have the same technology because it's very, very expensive. That means for the clothes to have some technology, you can, it's not today, what I would like to say, but because they win money by the utilization, by the clothes what we have. They pay a lot of things for the high-level athlete, and after they win another side by the clothes for us, you and me. You know, is the study. But for the clothes, this kind of technology, it's not allowed today. It's clear? Thank you very much, President. Yes, but this we can do it today. Yes, you can do it, but it's just for the medical application. To have the possibility with the yarn. The yarn, today the development of the yarn is, we call this the smart material. That means he have his natural position, and after just for one yarn, you tell him what do you want to go in compression, impression. What I showed just a little bit before is to all the fabric that we have for the high level, for example, with the Dupont Nemours, the latest technology is the smart material. That means is the fiber in 3D, and you can do what do you want to ask for the compression, for the pression. Everything is allowed with this kind of technology. Thank you very much.
Boa tarde, professor Fernando. A minha pergunta.
Professor Fernando, it's my question is to. So you said some concepts from Earth, and we have a constant to use. We have difficulty here in Brazil to apply it, but inside the look of you have here on UFRJ, you see there is necessary to clarify this, or just use the parameters from CIF, like you said, it tends to demand to the hospital, because I do not work on a hospital, so I don't know. We use as a different manners, like coding and quoting the barriers in a hospital environment. Do you think it's important or no? Thank you for your question. So I do not see the utilization of SIFI, how it were created to be utilized the way you put it, because he's the sister of SIG, is the sister of the functionality, and SIG from disease, and SIG from the mobility. So he's able to classify in terms of better applicability. From SIF has 3 models side the COSME. And COSME is an international initiative, like I said, showed you in the slide, that search to bring a objective way to find better way to find the tools and seeing the reviews and systematic ones. And we call 3 models, like we structure in group of the quadrilateral set. We see to determine clinical situation. So the question of quadrilateral set, we see another initiative from international one is a comment from Comet, yes, but it is letters with they try to utilize variations from clinical condition. So we have the higher number of the researchers, so they can use the same evaluations, so we see in the future they would be easier to see the results. So we have now the systematic measurements on. There's a lot of difficulty, the meta-analysis, to see the better evidence on the science, and then you have the grade that has a certainty of evidence. But then coming back here on SIF, we have a model who is suggested to orient protocol of measurements and the clinical practice and also the research. Thank you for your presentation, all of you. My question is for Annelise. I would like to know a little bit because talk about the relation of peripheric and cerebral, and if you have the knowledge about this technique, you have a large scale, you have some guideline there oriented to the technique, and there's these two questions I had. So the biggest use on the clinical practice outside the research is how you monitor the condition of the patient. So hospital, in ICU, and during surgery, you see a lot of articles that talk about the use on the clinical practice. During heart surgery, you can do a monitoring of the heart muscle, like, or even from the brain in determined cardiac surgery, depending on the brain oxygen, so we can avoid a death on some surgery. And then on rehabilitation, we could use as a way of a follow-up. We do not see that much, but as a research, I think we can use it. For example, I do a protocol, so I'm monitoring this patient, see if it improves this oxygen. So don't need to necessarily to be a research. You can use it as a monitoring. And the existence of a guideline for the use, it do not exist. It exists just by instructions we receive from the fabricants for the virtue to the limitations of the tools. Some of the limitations I do not quote from equipment is a little bit fragile, related to humidity. So when we had to utilize the streptoscopic from athletes, the elite athletes, so I should do a exhaustive situation. We need to protect the equipment, because if enters some water, you're going to lose the sensor, and if you lose the sensor, you lose it all. Because you have, especially on muscle measurement, is just one channel, because we learn to protect the sensor. So we use a plastic around the sensor, so to avoid that there's any water contact, to avoid the light in the sensor. We could improve with the time. When we started to get used to the technology, then we learned some strategies how to do it. So we protect the sensor with plastic. There's not going to be prejudicial to the sensor, because we are isolating to sweat, and then we do around the legs, so you can keep the equipment and doesn't fall out on the ground. So we do a lot of materials like Velcro, but it didn't get firm enough, so we put another cloth, like a black one, to avoid entrance of light. So there's a number of things we can do. And even with all of this, when I'm doing a measurement in a still environment, there's a lot of light of sun and all of these, even with the a fabric that's going to block the sensor from the light, and we have a problem with the measurement. So we need to see, there's a lot of procedures we need to do so we can have better warranty of the signal. So as the measurement is in real time, and how I know where the sign should be, we could visualize better if I'm having better collect or not, and if I have a bad one there, I need to see what is happening, if there's entering some light, or if example an area who has a bigger fat who is not coming to the muscle, and that what it should be measuring, if the brain oxygenation, if it is the hairs going under the sensor, you need to take back and then see what is the channel, and you need to fix it. So if the patient is still thin, it's the same thing. I need to modify the position of the sensor to find the place you want it to be. So we need to use a lot the CNA for electromyography. So we need to find the muscular center. We need to find, and there's a better warranty to have a better sign. But there is no guideline that is specific for this. Last consideration is a provocation for you can do, because I was curious. You talk about the black tissue, but it absorbed energy. Maybe the white is better tested if the white is going to absorb the light more than the black one to reflect, because black is going to absorb. I was a good student, I know it. And the black absorbs the light. And we did in our lab, we would to isolate the corridor because it's too hot, and we put a lot of black contact, and there's a lot of heat. And then we thought about it. We said, well, what is a white fabric? So do a test and see if it's better. Just observation. There's with black fabric from the fabric. Okay, I'll try. Thank you.
Thank you very much. I think I will stop the discussion. We are late. And thank you very much. Muito obrigado for this last one time of the day.
Peraí, não saiu correndo, que a gente vai criar um jeito. Como é que a gente vai fazer?
Do not run out because I'm going to do.
Que tamanho? Ah, o maior.
There's a list. Let's go for the size.
Só para ser contra, porque ele deve ser o maior.
Just be against it because it's the bigger. We're going to do the. Ninguém tá vendo. Mas ninguém tá vendo. Ninguém tá vendo.
Então, os nomes lá estão numerados? Ó, ou então a gente faz o seguinte. Você viu a lista lá? Não? Você tem noção? Não, né? Acho que ela não tem noção nenhuma, que ela está aqui dentro com a gente. Hã? Não, a gente pode fazer... Fala um nome, vamos ver se tem alguém aqui com esse nome. Sônia. Sônia, tem alguma Sônia? Aqui tem lista aí? Tá, então deixa ela lá buscar a lista e a gente... Deixa aí só dando uma... Não, ia ser engraçado, mas ela fala o nome... Não, não. Você falou Sônia, agora já desiste. Não, não pode mais. Ó, a gente vai tirar foto. Só para lembrar vocês que hoje a gente vai ter o jantar lá no Oliva. Tá, já vou te dar, peraí. Hoje a gente vai ter o jantar lá no Oliva. Então, estão todos convidados, é por adesão. Quem quiser ir, a gente vai daqui direto. Tá? Lembrando que amanhã às 9 horas a gente volta e... não esqueçam do concurso lá do Mevitih Moment, de postar as fotos para a gente ver no sorteio. Tá, a gente vai entregar o certificado. Fala o... Vamos lá, vou deixar na mão dele, ó, de 1 a 92. Escolhe um número de 1 a 92. 88, quem é? Luiz Maurício Pinheiro. Outro. Hã? 37. Jennifer Silva Mazini. Não está aí, vai para o outro. Cadê ela? Cadê? Então chama ela correndo. Tem 1 minuto aí para ela chegar. Cadê? Vamos tirando a foto aqui, então.